yes, I did.
Yeah, he's just giving a thumbs up.
Okay.
National GP healthcare
Yeah.
service.
Okay. That's good.
Sorry, just give Okay. Okay.
Third meeting of the Integrated Care Board for the North East and North Cumbria. Before we move to apologies for absence, could I just welcome everybody here, but also those who are watching online. We have a number of people here under the public access rules, and I'd particularly like to welcome Councillor Shane Moore, who is the leader of Hartlepool Council. Apologies for absence then, Debs?
It's Annie Laverty and Syra Malik.
Annie Laverty and Syra Malik. Thank you very much. Are there any declarations of interest for this particular meeting in addition to your declaration forms? Yes, please, Jane.
Hi, I'm Jane Hartley, and I work for Vaughan, and I have a declaration under item 9.7 because we are leading on the healthy communities and social prescribing element of one of the allocations of finance under item 9.7.
Thank you very much indeed. Moving now to the minutes of the meeting held on the 29th of September 2022. Are there any points of accuracy that anyone wants to raise? Thank you. Are there any matters arising not otherwise mentioned on the agenda? Thank you. Are there any items of any other business that anyone would like us to add to the agenda? Right. Well, just to say, I think we're progressing as far as allowing the number of items on the agenda to fall into more of an area of strategy and performance, and give us the opportunity to discuss the business of the ICB in relation to the provision of health and social care and population health. The agendas are still very heavy because of the number of governance items, central requirements, so we do hope over time to have fewer items on the agenda and more time to discuss them. I think we've seen a gradual improvement, but we would look by the next meeting to see an even better balance there. So thank you for bearing with what is quite a heavy agenda again, with a relatively limited amount of time for discussing each item. So if we could move now into item 7.1, and David Perdue, our Executive Director of Nursing, is going to introduce this item and also introduce the visitors that are attending for this item.
Morning, thank you, Chair. So the item is around our learning disabilities and autism, building the right support, so our strategic plans for improving the lives of people with a learning disability and autism. And I'd like to introduce the Twisting Ducks. We are Jay, Mark and Zoe to do their film.
Often don't get good care and treatment. I know this from all experience. While I was in hospital a few years ago, I was very ill, had tubes in me and I couldn't talk. When Mum was not there, I felt dead lonely. The nurses did not know how to communicate with me. They just presumed I couldn't read, write or draw. It made me feel lonely. My mum had to teach them how to communicate with me. When they did, it made me feel a whole lot better and included.
Hi, I'm Mark from the Twisted Ducks Fiat Company. I've come today because I think it's shocking that people with learning disabilities like me die earlier than everyone else. Don't you? At the Twisted Ducks, we make accessible health information. We do this in a number of different ways. We make clear, accessible, easy-read information and surveys. We make accessible film-based resources that support people to understand health information and issues. We offer training to health and social care professionals around some of the main issues that affect people with learning disabilities and autistic people. We are now going to show you a short film we made for the Leader Conference called 24 Years Worth Living.
Stay. What's in a number? Looking back to yesterday, making plans and making hay, all our dreams along the way. What's in a number? Loving life. This is our time. Holding on to 24 years worth living. I'm proud of who I grew to be, of all the possibilities. I've been a star upon the screen. Did you see me? I wrote a book for you to read. I met the girl of my dreams. I found the friends I truly need. So can you see me? What did you do today? Did you while the time away? 24 hours in a day. What's in a number?
Well, thank you very much for those opening contributions of very, very valuable insights, and also for the film. David, over to you now to take us through the paper.
Thank you, Sue. So, I mean, that was really a great film, and the Twisted Ducks performed that and a number of other films at our Leader Conference, just to highlight that still, after all the years of reviews, we still have a differential of lifespan of 24 years between somebody who has a learning disability and or autism. So the paper will take as read, and we just really wanted a conversation really in terms of what we're doing and our progress along the work that we're doing, and just around, obviously at the moment there's been lots of television programmes around people with learning disabilities and autism, and there's lots of focus, especially with the CQC, on all the organisations they've visited in terms of how learning disabilities and autism people are treated within our acute settings, but also people in communities, and actually community support packages, how are they being monitored. So it was an open discussion.
Okay, thank you. We'll open it up for discussion in a moment, but I think your covering report, David, with the key points gives a good focus for discussion, and then perhaps towards the end of the discussion you would highlight what you think the most important areas for improvement are, bearing in mind that we're aware that services around the country are facing similar challenges, but the ones which are particular to the North East and North Cumbria, it'd be very helpful to have those on the table. So points that people would like to raise, or questions? Yes, please, Kath.
Thank you. Obviously welcome the report and welcome the work that's going on in relation to this particular area, particularly as a challenge for us when the numbers of children that we are identifying with special education needs and disabilities are increasing, and the support services that are available to assist parents in their care of those children have not particularly increased in that time. So I welcome the report and the impact that will have on our services for children across the region.
David.
Thank you.
Would you take the microphone a little bit nearer, please?
Will do. Yes, thank you, David, for the report, which is very rounded and very realistic and clearly highlights the enormous challenges faced by the service. But it is assuring that throughout the document you do make reference to engagement with patients, families and carers, and that is very, very much appreciated. It's true to say that this particular item on the agenda elicited the greatest number of responses from colleagues throughout the 13 health watchers in the North East North Cumbria region. I have a significant list of them here, and I think too many to be fully articulated now. So I'd like to suggest if I mention one or two, but if it's okay, Cillian, that I write to David with the points raised by colleagues, which will be, I think, a more thorough way of informing David of what the views of the Health Watch Network is on this very, very important topic. But the ones which have been mentioned, just a few, difficulties with accessing information from some healthcare services, the accessible information standard not always being maintained, improving the working and communication between the learning disability team and the mental health team, extended use of personal budgets to make them more person friendly and so on, hospital discharge, another issue which has been raised, improved training and education for families to enable them to support people living at home more carefully, and so on and so forth. So there are many, many issues, most of which have been highlighted. So I think if we can, if I could communicate those lessons to be learned to David, rather than go through them in greater detail now, might serve the purpose of the learning disability and autistic people.
Okay, thank you very much. Sam.
Thank you, Chair. I just wanted to thank Zoe and Christine Dance for such an impactful film, and I think your real skill, particularly around communicating in ways that I think gets the message across. And I also noted the recognition of Mary's contribution to that film at the end, and just wanted to place on our record our thanks to Mary, who from the note at the end of the film would appear is no longer with us. And I think it's important that we just register that and record that. 24 years is a huge amount of time, nearly quarter of a century. And I think in terms of the report on page 23, there's a table in there which also has a number of numbers in it. And I think it's really important that we recognise behind each of those numbers as a person. And these are people who are currently receiving care in specialist services, and we're very committed as an integrated care board to look at their discharge pathways and getting them home to their communities. We recognise that work's been underway for some time, but we've got quite a bit more to do, and I think it's not only the people who are represented in the numbers of those tables, but also making sure that our pathways of care support people to maintain their independence where they can and live their life to the full. And I recently attended the Inclusion North group, which is called the Dying Too Young group, and I really look forward to a day when we don't have to have a group which is called Dying Too Young. And I think the human aspect of this paper, and I think you really brought that to life with your film, is something that I'm sure we all around this table will recognise and reflect. And I think it's important that we keep this on the agenda and that we bring regular updates here to the board in spite of the oversight in the paper. And Chair, I'd sort of suggest that we do this regularly through our integrated performance report so that we can demonstrate that we are making progress in this area.
Okay, thank you. Nicola,
Yeah, I think I just want to...
a bit closer to the microphone, please.
I think I just want to echo everything that's already been said, but particularly thank you for the video, because I think that does bring it to life. But I think the key bit for me is about the partnership we have with people who require support and their families, because I think that starts at the very early age and something that we need to do better together, certainly from local government and community and voluntary sector perspective. But the key bit is that the autistic people with learning disability and their families are actually centre stage to that, and it's about us supporting people to live healthy, well and safe in their communities, wherever that might be, rather than us prescribing what we think somebody should do. But I think the other thing that I would ask of this board and the ICB, as well as our local government colleagues, is that we don't just think about people with learning disability and autistic people separately. We begin to think about it through all of the agenda items that come through here in relation to cancer, in relation to respiratory issues, in relation to everything that we do. We begin to think about those 24 years and always relate back to that. So we focus on those individuals in hospital that need to not to be living in hospital, because that's where they're living at the moment, but we also focus on the how to keep people healthy, well and safe. And I think always focusing on that will really make a difference.
Thank you. John, you're going to comment? Yes, I remember. Yeah, I remember before the board was formed, when we were in shadow ICS form, coming to a meeting of the clinical commissioning group chairs, which you chaired, and we had a discussion there about the needs of people with learning disability and autism. And the thing that struck me from that is how many were misplaced in facilities which they shouldn't have been in or were in too long, and how difficult it was to resolve some of those problems. That may not be the point you're going to raise, but you probably remember that discussion.
Yes, I do, and I suppose I just wanted to echo again some of the things that have already been said, is that there is a real need for this, and there's also a real challenge about it. If we don't get this part right for our most potentially vulnerable people in our society, in our communities, then we're not going to succeed as an ICB. And again, I welcome some of the recommendations that have been put in there, particularly about bringing some of the indicators back to the board so we can keep abreast of it. And it talks about a 2-year programme, but it talks about a 2-year programme as well within partnership. And I think there's a number of tests there. It's a real test for this partnership about how we go about doing that and how we actually can show that transformation. So I suppose I'm just reinforcing the fact that if this isn't done, then I can't see how we would succeed as an ICB in terms of delivering what we need to deliver. That's the only point I want to make.
Okay, thank you very much. Are there any other comments? Yes, please, Rod.
Yeah, no, again. Can you hear me? No. Yeah, that's fine. Again, very supportive of the paper, and I just wanted to make one point. the community sort of alternatives and supports highlighted here are absolutely crucial, because once people get into hospital, we know many times it's not the right place. It becomes really, really difficult for them to get the right care and then to get out in the community again. But along with that, what I thought was missing from the paper, and it might be in the detail behind it, is the workforce implications of how we're going to achieve that. Because none of the outcomes will be possible over the next 2 to 5 years unless we get that right. And that includes having the help of our third sector and for the people who have, learning disabilities and are on the autism spectrum.
Thank you. You may want to come back on some of these points, David. Mike.
Echoing Rajesh's point about the workforce, and the paper touches, and I'm really pleased that it does touch on the fact that a lot of the care staff who do the highly skilled work supporting families are paid minimum wage, and as a consequence there's a lot of care breakdowns, and that loss of continuity can be catastrophic, and I've seen that firsthand. I think we need to recognise that it is high skilled work and remunerate accordingly, and that will hopefully reduce some of that loss of continuity and bring more people into this sector, which we valuably need.
Okay, thank you very much. Yes, please, Tom.
Yeah, thank you to Liam. Just building on comments around the workforce, I totally agree that the specialist workforce is really important here, but also the wider system needs to be able to recognise and adapt to the multiple needs of our communities, particularly some of our more vulnerable and disadvantaged communities, which also means skilling up our wider workforce as well, particularly on issues like learning disability and autism. Last week, Eileen and I were at an applied research collaboration event where we heard more about how we might work differently with some of our key communities. We actually heard from a community interest company in Gateshead called Lawnmowers, and they provide training through theatre to the wider workforce, particularly our GPs, our practice nurses, our wider nursing trainees going through the academic routes, and it was really, really valuable to see how that kind of training and insight could be delivered differently by people with learning disabilities. Really fascinating to see, and actually part of structured academic research as well, so we can look at the components that work as part of that training and seek to expand it further. So I'd fully recommend David and Cindy the details that we look into that and how we might be able to expand that kind of provision.
Thank you. Any other points? Yes, please. Jane.
Just to add to that I think it perhaps doesn't come through quite strongly, but I'm sure there's an intention there, to being more creative in how we commission services in the community, and actually using user-led organisations that actually embed and involve people with learning disabilities and autism, and moving towards a culture of not always thinking that the NHS are the only people that can do this. And I believe there is a commitment to do that, but I think it will require a more creative commissioning environment to make that happen.
Okay, thank you very much. Anne Workman.
Thank you, Liam. Just to say thank you to the theatre group. Fantastic way to start the session this morning. I think we've got a huge opportunity as an ICS around this, and particularly working together around housing providers and providers of care and support, but really getting the voice of the person and the family involved in this. I won't repeat some of the things that have already been said. I really dislike the term trajectories. It is about people, and when we see these reports time and time again, and the word trajectories are there, just talking about people and what it means to them. But yeah, really, really good item. Thank you.
Thank you. Nicola.
And just a final point, and it links to the workforce. People may or may not remember there was a young man who died with autism, and his mum, Paul McGowan, has really championed the fact that people in all of our organisations need training in terms of how to work with support and communicate, and goes back to that very early point about communication, and that training is actually being rolled out right across. I mean, it's a national mandate now, but it is going to be rolled out right across the North East and North Cumbria as well.
Okay, thank you. I'll let David come in a minute to pick up any of those points and also give us a feel for what he thinks our priorities should be given the state of services and care in this area. But just to, several people have mentioned, and John said it would be a test of how integrated we are really if we were able to address this area of service properly. But it does seem to me that it's a very multi-sectoral input, and some of you have given examples. So I just wondered if you look at, for example, connections to education, connections to employment, connections to housing, whether those links are strong enough and focused enough. So David, maybe you could pick up any points from the discussion, the point I've just raised, and so also areas for improvement.
So I think in terms of the workforce, I don't think anybody underestimates the difficulty in the workforce, and that's from a kind of a registered professional perspective, as well as the care and what we need to do. And you're quite right in terms of these are very specialist skills and we should pay people accordingly. So there is some work being done that we're going to pilot across North East North Cumbria, looking at nurse associates working as part of social care into learning disabilities and autism. I think in terms of the Oliver McGowan training, that was going to be vital for organisations. I've met Paula, she's an incredible woman, and actually a big part of this, and I went to an event last week, and the thing that struck me, and again we had experts by experience, and they said, look at my strengths, not at my disabilities. And that was the biggest thing that struck me that day. And as part of this, again, if you consider only 6% of people with a learning disability are in employment, and actually we need to change some of that. So you're quite right, Liam, in terms of how we need to work in partnership as anchor institutions. I think we've got a vital role in this. So that's one of the key works we'll do at the moment. I suppose trajectories are something that we look at, because actually the waiting time for a diagnosis of autism currently is completely unacceptable, and it's not something that we look at as purposefully as we do a cancer waiting time, and actually it's equally as important. So we will look at kind of the measures and how we're going to plan those. And then finally, I think it is around co-production and how we use skills of experts to take this piece of work forward. So I think we have a vital role in the ICB to work in partnership with all our providers.
Okay. Thank you. Well, I'd like to leave this item now, but I think with a commitment to return to it with a follow-up report in a few months' time. But I'd particularly like to, in addition to David, to thank Jay Hare, Chief Executive of the Twisting Ducks, and to Mark and Zoe for coming today and giving us some really deep insights into the challenges, and also steering us, I think, to some of the areas that were picked up in the discussion. So thank you very much for coming. You're welcome to stay for the rest of the meeting, but it may not be all of interest. But in the meantime, we look forward to working with you, and thank you very much. Moving on to the next item then, this is the item 7.2, Sam, your Chief Executive's report.
Thank you, Chair. So I'll take the report as read, but there were just three items I would like to touch on. The first is to convey our heartfelt condolences to the families of Christy, Emily and Nadia. These were absolute tragic losses of life, deaths in our mental health services, and the reports into their care, which were incredibly hard reading, were published earlier this month. And in terms of our commitment and our role as an integrated care board, we continue to work and support Tees Eskom Weir in the improvements that they are making to services. And indeed, we also have actions, particularly in terms of ensuring that the care pathways for people who have needs, like Christy, Emily and Nadia, are well met. So we'll certainly bring updates on the actions for us as an integrated care board back through future meetings. I also wanted to touch on the publication of the East Kent report into maternity services. Now, this report clearly was into maternity services, but actually I think there are connections from aspects of culture and openness and transparency and working with families that touch on the reports published by Tees Eskom Weir, and also pick up the issues that David referred to that have been publicised through the media, particularly through Panorama and dispatches around the culture of mental health services. My report provides a summary of the East Kent report, but I'm really delighted that our chair, Sir Liam, has invited Dr. Bill Kirkup to our meeting in January. And I think whilst we'll have a conversation at that meeting and explore the specific learning for maternity services, I do also think it's an opportunity for us to make those other connections around culture, around openness, transparency and working with families. And I look forward to that discussion at our January meeting. Now, the paper also provides an update on the work that we've been doing to establish ourselves as a learning and improvement system, and it also includes the 7 priority areas that have been identified through the work that we've been undertaking. And I'm delighted that the first area, which is a particular focus around children and young people's mental health, is already getting underway, and want to thank our 2 mental health providers who are working closely on the summit that we plan to hold on children and young people's mental health services. And our next event, our Learning and Improvement System, is in mid-December. I think the important thing to note in the work we're doing on the improvement and learning system is that this is very much co-producing with all members across the integrated care system. Our big opportunities for improvement in terms of quality, and look forward to taking that work forward over the year ahead. And then just finally, I just wanted to briefly touch on COVID and flu vaccinations. We did have quite a comprehensive report at our last board meeting on this, and we are making very good progress with regard to vaccination for COVID. We are supporting and encouraging all our health and social care workers to take up their vaccinations. Whilst the figure in the paper was at the time the paper was written, we have improved slightly on this, and our Chief Medical Officer, Neil O'Brien, has written to all of the organisations asking the trusts and providers to encourage workers to take up those vaccinations. I think it would be fair to say we have been experiencing perhaps what some may term a bit of apathy across the wider population in terms of these vaccinations, but just wanted to use this opportunity again to promote and encourage all colleagues across health and care, but also members of our population who aren't yet vaccinated, who are eligible to take up their vaccinations. Thank you, Chair.
Thank you very much. Are there any points that you'd like to pick up from Sam's report? It is good news that Bill Kirkup is coming in January. Of course, he's done a national. Apart from looking at Kent, he was commissioned to do this nationally. So it's good that we have got him on our agenda. He obviously has connections to the northeast and earlier forms of organisation at regional level. But I think I'd particularly be keen to ask him what sort of things we should be looking at. I mean, there's a weakness, really, I think, in measures of the qualitative side of health care, whether it's culture or other aspects. But if we were fully capable in that area, and I don't think there's any part of the country that is yet, we would be able to exercise surveillance functions, not just for outbreaks of flu and measles and things, but we would also be able to look to see if things were going wrong in the delivery of our services. But I think we're quite a long way away from having the kind of data that do that. But Bill is, having done several of these inquiries, he was involved in the Morecambe Bay inquiry. He was also involved in an entirely different way in the Hillsborough inquiry as the medical advisor to that. So he's got a lot of experience in this field, including the sort of data that you need to find problems which might not otherwise be obvious. So I'm looking forward to that discussion. And then on winter, I mean, we haven't, I think, yet seen the kind of, maybe this is something that Neil might want to answer, we haven't yet seen the peak of these two dual problems. Does that mean it's not going to still come, or will it come, or what's the latest thinking from the modelling side?
So flu has arrived, and there are admissions to hospital now with individuals with flu. It's slightly higher than where we would expect looking at previous seasons, but we are expecting that number to increase. And that on the backdrop of still a significant number of people in hospital with COVID. So we are watching the numbers on a day-to-day basis. It's quite possible that we could get quite a surge in our flu cases on the backdrop of COVID, which will put significant pressure on our health services. So we're doing as much as we can to plan for that in the background, but obviously the main intervention is getting our vaccination rates up where they need to be, which, as I say, in the North East and North Cumbria, we are certainly doing a good job with that, but we're certainly watching it as winter goes through.
Okay, thank you. Jacqueline.
Thank you, Liam. Just to mention that during the next few days we're participating in an emergency planning tabletop exercise where we're looking at a scenario which is a mix of industrial action and elevated levels of admissions to hospital due to seasonal issues such as flu. So we'll be building that into our, we'll be taking learning from that exercise and building that into our plans for the coming months.
Okay, thank you. Neil?
If I can just add as well, it'd be prudent to also mention that we have had our first couple of outbreaks of flu in care homes, and the letter from the centre has come out advising now that flu is circulating in the community, and that GPs are now directed to prescribe the preventative treatment in any outbreaks. So that just came out at the back end of last week.
Yeah. Just before Anne comes in, not everybody will be knowledgeable about flu, but just it might be helpful for me just to give you this bit of information, that essentially there are many different variants of the flu virus, and two different changes can happen. So we tend to get a strain of the virus that's more or less in the same form for several years at a time. It doesn't always happen like that, but gets a little bit more virulent from year to year. But and the vaccine is predetermined on a global level, so but usually based on what's starting to happen in the southern hemisphere. The WHO advises on the content of the strains to be put in the vaccine. Sometimes the match is very good, other times it's completely off. So that has a bearing on it. But essentially, apart from the kind of, if you like, the stability where you don't have all that much change, the two big things that can happen, one is called an antigenic drift, which means that the protein that moves quite a long way away from the seasonal strain, and that then leads to a very big outbreak in the flu season. And so this is what could be happening now, we're not sure. But probably the worst example in the last 20 years was the 1999-2000 outbreak, where there was quite a big drift, and we got the highest number of cases for, I think, 15 years, very large numbers of admissions. But the key thing about that aspect of flu, the drift, is it's mainly older people that have the biggest burden, some younger people and children as well. But then the pandemic strain is the one that comes about through what's called an antigenic shift. That's a much bigger jump. And it comes about usually because an animal or bird flu virus combines with a human one and goes into a sort of mixing pot, and then you get a version to which the population has very little immunity. But the people who do have immunity are generally older people who've been through so many flu seasons before. And what you tend to see with the pandemic is a lot more children and young people affected. And although the swine flu pandemic, which I managed when I was chief medical officer, now said to have been mild, it still killed 70 children that year, and a lot of young adults in intensive care. So the big danger, and when we see a lot of bird flu viruses around at the moment, is that will combine with a human strain and produce another pandemic. And the pandemics of the past, there haven't been that many to learn from, but obviously the Spanish flu, beginning of the 1900s, 1958, 1968-9, and then 2007-8. That's it. So there's no frequency. They can happen any time. They could happen 2 years after the last one. But ultimately, the only way to combat it, apart from being prepared, is to go down the route of trying to invent a pluripotential flu vaccine, which the mRNA vaccine people are now trying to do, which would give you advanced protection against all or most known strains. And that's a huge scientific jump. But in the light of the progress with the COVID vaccines, it might be possible now, whereas 10 years ago you just said, well, it's just not possible. We just have to wait and take the consequences. So that might be helpful to people as just a little reminder of the biology behind it all. Anne?
Yeah, it was just a quick comment, Liam, just following Neil's mention of care homes and flu. And obviously the local authorities are working locally with our providers in terms of winter preparedness as well, just to support. And perhaps now that we've seen flu in some of the care homes, it might encourage some of those social care workers to get their vaccination, which we're continuing to get that message out.
Yeah. Okay, thank you. Are there any more comments or questions on Sam's report? Yes, please, Kath.
Just really a very quick question about you talk about the overall take-up of vaccinations within schools is 57%. Oh, no idea if that's good, bad, or indifferent. So it would just be useful to know whether or not this is a better year than normal, and actually what can we do to increase the uptake potentially if that is a low.
Neil, do you want to take that?
The figures that's in the report, there's actually some movement on those. Actually, our school-age vaccination programme for flu is well above national average. We've always been good at vaccinating in the North East and North Cumbria. Yes, I haven't got the figures to hand, right, but we are benchmarked above the average. We started a little bit slow because we purposefully went to schools with more vulnerable children in, and then we've started to go through and we're ensuring that the rollout of the school programme as well accounts for any health inequalities as well as we do it. So we could be better, we always could be, and again, it's a difficult population to vaccinate because a lot of parents. It's difficult to get the message across as to why it's important for their children to be vaccinated for flu, which is why it's quite difficult. But we've used behavioural insights work to try and improve that year on year, and we'll continue to do that. But we're not in a bad place.
Great. That was just my issue about whether or not that was good or bad, and I couldn't tell from the report. Just one other quick query as well.
Yes.
Sorry. The summit for children and young people around mental health and waiting lists, etc. I would be interested in receiving some additional information in relation to that, but also how could our parent carer forums in the region help to support that work moving, to support that summit? So just a statement really rather than a question.
Okay.
Yeah, really happy to pick that up, and the design route for that will be inclusive in terms of the involvement of children, young people and the parent and family carers.
Thank you.
Any other points anyone wants to raise on Sam's report? Okay, thank you very much. We move on then now to item 7.3, which is the integrated delivery report. And Jacqueline, you're going to take us through that.
I am, thank you, Salim. So, as in previous months, this is a very...
Need the microphone a bit closer.
Yeah, I'm trying to... Ooh. There we go.
Good.
So, thank you, Salim. As in previous months, this is a very detailed report as it is structured around both the current year planning priorities and the NHS oversight framework, which applies both to integrated care systems and to all of our NHS trusts and foundation trusts. So I thought what I would do is just pull out the headlines and give some information, starting with the key changes from the previous report and then just going into a bit more detail. I'm going to defer to my colleague over there, the Chief Nurse, in terms of any further issues he wants to pull out of the report in relation to quality. So just starting with the key changes then since the last report, in terms of quality, there's been a recent CQC inspection in one of our foundation trusts, North Tees and Hartlepool, and their overall rating has been given as requires improvement, which is compared to their previous rating of good, and kind of relates to the points Sam was making earlier around the inspections that are going on at the moment and the issues they're picking up in relation to the range of pressures on our providers. Also, and has linked to the previous report, CQC has recently inspected the learning disability and autism wards of both the Cumbria, Northumberland and Tyne and Wear Trust, and also Tees, Esk and Wear. And again, we've seen a downgrading of the rating for those parts of the services in those organisations, although it doesn't affect their overall rating. And lastly, a key change since the last report is that South Tees and Sunderland Foundation Trust maternity services have been removed from the enhanced surveillance process, although quality assurance is obviously still continuing around all of the actions there through their quality review group. Shall I go to you now? Is there anything else you want to raise in terms of the quality report? Obviously, huge depth of detail. I should mention also these reports are reviewed in detail in both our finance, performance and investment and our quality and safety board committees. So it's really just the highlights that we're drawing out and the opportunity to take questions here.
So just in relation to North Tees and Hartlepool, they had children's inspected, maternity inspected and well-led inspection. And following a downgrading of their maternity services to requires improvement, they are now on the National Maternity Improvement Programme. So we met with them yesterday to look at kind of that programme. So it'll be up to a year in terms of greater support, which it comes at a good time in terms of obviously the East Kent report and the recommendations coming through that. But just in general in quality, maternity service is obviously very high on our agenda. In terms of Ockenden 2, the 16 immediate and essential elements of that report are being combined with the East Kent report to have an overarching maternity improvement plan that should be published in February. So we have a meeting planned in March to look at all the different elements of that, to take that forward. The important element being that it's not just around maternity services, it is around neonatal services and services around transition. So it'll be a much more combined piece of work rather than just focused on maternity. And the other bit around quality is just, so we've had 14 Never events year to date, including the title as being a never event, that they shouldn't happen. An awful lot of them relate to invasive procedures. So we're just doing a review at the moment in terms of both compliance with the WHO checklist, but also with local safety standards for invasive procedures and national safety standards for invasive procedures, to do some learning across the different organisations.
Thank you.
Shall I move on?
Yes,
Chair?
please do.
Okay, so I'm now going to raise some headlines in relation to the performance section of the report, which is largely relating to waiting times in terms of accessing care. In terms of the key changes since we last met, first some good news. The report refers to the Tier 1 and Tier 2 escalation process that NHS England runs in relation to both cancer and elective waiting times. And what they do in relation to these waiting times is that they segment all of the trusts in England into quartiles and put them in either a Tier 1 or a Tier 2 category of escalation if they're in the bottom half or indeed the bottom quartile in the country. So South Tees NHS Foundation Trust has been for the past few months in a Tier 2 escalation. That's the less serious of the two, but we've seen really significant improvement in their performance. So their tiering was relating to patients who were waiting more than 62 days from referral to either treatment or discharge for suspected cancer. So a really positive result there, and not only have we been really pleased to see the progress there, but we've been able to share some learning from South Tees with some of our other organisations in the patch, which will be helpful in addressing some of the remaining cancer waits, which are longer than we would want to see for people in the region in our other trusts. North Cumbria Integrated Care NHS Foundation Trust remains in Tier 1 in relation to their cancer waits. However, again, we've seen some really positive progress, about a 30% reduction in the number of people waiting over 62 days on their pathway, and we are expecting them to be stepped down imminently out of that Tier 1 process. On the flip side, unfortunately, Tees and Hartlepool NHS Foundation Trust have been moved into the Tier 2 process for their cancer waiting times, and that relates to a serious increase in the number of people waiting over 62 days in that trust, and so we've started a process to support them to improve that situation. And Newcastle University Teaching Hospitals remains in Tier 2 for both its cancer and its elective waiting times, and we continue to work with them to develop their plans to reduce the number of people waiting longer than this year's targets. The other area that I really wanted to draw out, Chairman, in terms of changes since the last month is that unfortunately we continue to see some really significant pressures and some further deterioration in waiting times around our urgent and emergency care services, and the 3 points are highlighted in the cover of the report. The first is that we've seen quite a significant worsening of the waiting times for Category 2 ambulances. These are so Category 1 would be the sort of the most significant concern, where there's a concern of immediate risk to life, where we expect an 8-minute response, and we are still meeting that target in the region. However, Category 2 would be the next most serious response, and the target is for a response within 40 minutes. We've seen our performance deteriorate from 40 minutes and 45 seconds in September to 57 minutes in October, which is obviously of significant concern, although it does still compare favourably, if we could put it that way, to the national position, which is now over an hour. We have seen also a deterioration in the number of hours lost per day as a result of these, as a result of ambulance handover delays, and we've also seen an increase in the number of patients waiting over 12 hours from following a decision to admit to actually getting into a bed into our hospitals. Now, as you know, later on the agenda we've got an update on our urgent and emergency care winter and operational resilience plans, so I hope you'll see there a read across of the specific actions that we're taking as an integrated care board and with our partners in the wider integrated care system to address some of these worrying trends. But clearly, as we go into winter, we would be concerned not to see much more deterioration in relation to these standards, and so that's why you'll see that the key areas of focus in our plans is very much around supporting timely ambulance response times and indeed reducing handover delays. So there's just a couple of other points, Chair, if I may pull out from the main body of the report, and then happy to take any questions. I'm going to leave the finance section because we have a separate finance report coming up on the agenda. So just wanted to draw out a couple of points in relation to primary care and to elective care. So in relation to primary care, really a significant increase again in the number of GP appointments that we're delivering within month compared to the pre-pandemic levels. So a total of 1.5 million in September, which is really good to see. And we're also continuing to outpace the rest of the nation in relation to the percentage of our GP appointments that we're able to deliver face-to-face, which again I think is positive and no doubt welcomed by our community. We do still see a relatively high do not attend rate, so 5% of all appointments are not attended by the person who made those appointments. So that's obviously an area of focus in terms of improvement, and there's a bit of detail further in the report about the work that we're doing to support practices to work on that. However, again, that is better than the national rate. In terms of elective care then, just to say that in terms of the very longest waits that our patients are experiencing, so over 2 years from referral to treatment, unfortunately we haven't fully eliminated those waits. I've spoken at board before around the issue we've got with the complex spinal service in the region in Newcastle University Teaching Hospitals, but pleased to say that they're continuing to outpace their own plan in terms of reducing those waits, and had the benefit of visiting the trust and talking to the team, including some of the surgeons there, about the very detailed work that they're doing to continue to address that problem and also set themselves into a sustainable position for the future. So good to see a lot of very detailed work going on there, and some mutual aid with local hospitals to help them address those backlogs. What we are seeing, however, is a worrying trend nationally and locally of the overall waiting list continuing to grow. So the waiting list is at an all-time high in the region of 344,000 people waiting for elective treatment. It's a very large number, and no doubt in future meetings we'll want to have a bit more focus on what we're doing around both expanding our elective services to meet that demand, but also modernising and redesigning them so that we make best use of the capacity available in the region to meet those demands. And there are some opportunities around both productivity and new ways of working that might help us address that backlog, in addition to growing the overall size of the service. So I think, Chair, that's all the things that I wanted to draw out in my highlight report, but we're happy to take any questions.
Okay, just before people ask questions, Neil, would you say something about the work you're doing on ambulance delays?
Sure. It might come up in the winter, and it will certainly update. We held a rapid improvement event. We've had two since the last board. The initial one was focused around managing safety of those individuals who are waiting for an ambulance, and that was about enhancing clinical triage capacity within our ambulance service to ensure that we've got the prioritisation correctly, and we've implemented a number of initiatives already relating to that. The second event that we had last week was focused purely around the ambulance handover delay. It's a very difficult measure to improve because the causes of it are very varied, from flow through hospitals, processes within emergency departments, processes around access to urgent community response to discharge. So it was very complex, and we recognised that in the event. We've made a commitment, which is currently, as this just happened last week, we're writing up to take to our chief executives and discuss with all of our providers, that the system has a red line on handover delays at 59 minutes, so that no handover delay exceeds that 1 hour. When it gets to that point, then immediate handover would occur. the background to that is actually looking at the entire system risk for individuals who are experiencing long delays for actually not seeing any clinicians who are at home and asking for urgent response. We feel that the greatest risk are those unseen people who are at home and are waiting long time for an ambulance to come. So the feeling in the room was that although hospitals might take on individuals from crews earlier than they would normally because their departments are full, we still think that is a safer situation than actually individuals who are waiting very long periods of time. So that's getting written up at the moment. We will then, there's a lot of initiatives behind that on how units can actually deliver that. And I'm working with my co-chair of the Urgent Emergency Care Network, Sean Fennick, who's the Chief Operating Officer and a physician at Sunderland, to get that out over this next week so we can implement it for this winter.
Thank you very much, Neil. And David, you want to say anything about the work on delayed discharges?
Yeah, so we've reviewed everybody in all the acute providers in terms of where they are with the 10 high impact interventions for effective discharge. That's all being reassessed at the moment. And obviously we have our announcements of our share of the 500 million discharge funding. So we're just working through with ADAS colleagues at the moment to look at actually how that funding needs to be assessed, and we will do that at a place level to support that as part of the guidance. So the guidance is that the funding has to go through local health and wellbeing boards to agree the areas that we're going to look at that funding. There are a number of different areas. So from our acute providers, the big thing is around workforce and having the effective workforce for domiciliary visits so people can go home. The big driver for this will be that everybody has to go through a home first approach to this, and it should have discharge to assess really embedded within their services. So we will agree finally kind of our first report back to the centre has to be done by the 16th of December. So we'll have plans all in place by then.
Okay, thank you. And Ken, you're chair of the Provider Collaborative. How is the Provider Collaborative engaging with all of this?
Well, I think... Can you hear me? Yeah. Is that on? I'll try and shout. Is there a button? It's on. Sorry. As you heard Neil say, all the providers, I think, in the region, not just providers, it went wider than just providers, because it isn't just a provider issue, as you've probably heard Neil articulate. We're engaged in that piece of work, particularly on handover last week. I think, from my sense, Liam, is we've got to somehow break into this cycle somewhere. I think what you've heard Neil articulate around the 59 minutes is an attempt to do exactly that. Let's set a target. Let's manage against that and see where it takes us. Because if we can deliver 59, we can deliver 45. We can do 45, we can do 30. So I think we've broken into that circle, and we'll see how that works when we get into practice. But the one thing we're absolutely clear about is that this must put more ambulance teams back on the road quickly to tackle the issue that was raised at the start, which is the risk of people at home who aren't getting access and actually aren't transparent sometimes to some of our services. So urgent emergency care, as you would expect from all providers' perspective, Liam, is one of the key, if not the most key issue that we're dealing with. So we're all engaged in it.
Okay, thank you. And how is it looking in primary care at the moment, Mike?
And I think the numbers pan it out really. The growth in the number of appointments being offered is the demonstration of the high level of demand. Certainly, I think primary care are feeling a lot of that the ambulance delays and the delays for emergency care. That all ripples back to primary care. And just to put some meat on the bones of that, when often patients come to primary care to the GP, where historically they might have gone to A&E because they're feeling unwell, but they're terrified of the long waits at A&E. They come to the practice, the decision is made they need to go into hospital, and then the ambulance delays mean that the patient is in the practice for quite a long time, sometimes quite sick. And that then takes a lot of practice resource to attend to those patients, and that then causes further delays in primary care. So it really does demonstrate that these are all system issues, and every bit of the system connects to another part, and there's no way of hiding from the growth in demand. Primary care, it's great to see that the number of appointments have increased to demonstrate that we're rising to meet the need as best we can.
Okay, thank you. And Neil, yes, go ahead.
Just again, just to mention the Urgent Emergency Care Network Board, from the providers, it's really great engagement from our provider chief executives and medical director, nursing director teams into that board, right the way through to our local A&E delivery boards. The absolute focus of everyone in the system is doing the right thing for patients and for safety for this winter. We're putting as many short-term interventions as we physically can do for this current winter, but also having our eye on the kind of medium term to get that performance back to where we've historically had it, that we're trying to recover from. But there really is fantastic engagement and commitment across the board in health, social care services to try and make this winter as safe as we possibly can with what we have.
Okay. And on the delayed discharge front, Anne, Kath, anything you want to say about how the world of social care is relating to this at the moment? Are we seeing any movement really, or are the same problems still occur?
I think the biggest issue, Sir Liam, is around the care sector, which does cause us some issues. I think the place discussions are really, we work extremely well within our places in terms of the shared responsibility and ownership to get people out of hospital and to get them supported as well. So that continues. I think the issue around acuity of people coming out of hospital, whether they're going to their own home, care home, reablement or wherever, we see more and more of people needing 2-to-1 care and support. So I think we're dealing with a population who are older, multiple long-term conditions, all of the stuff that we already know, but the joint working and the ownership, shared responsibility, I think is very strong, in particular in our own areas. So yeah, hard work.
Okay, thank you. Kath, do you want to add? No. Okay. Nicola, are you seeing, because you've got quite and Dave has as well, but you've got quite an overview of the system in the north and in Cumbria. North Cumbria, what are you seeing, and are you seeing any big breakthroughs?
I think what everybody's described so far about all of the bits of the system being interconnected, you absolutely see that when you look right across the system, and I don't think there's anywhere that's escaping the pressure in the sense of that acuity, workforce issues, social care, and nursing care provision impacted by workforce. I think in terms of big breakthroughs, I think for me, the issue about how do we work together at place to begin to work through some of those systemic issues is really key. And I think the fact that all parts of the system are involved in the urgent emergency care board is really important, because there is something as well about sharing what we do, because historically as smaller organisations we've not been as good at sharing as we possibly could have been, and I think that goes the same for ADAS as well and ADCS. So it's really important, I think, that we look at this from a system point of view, share what we've got, use the new discharge monies to the best effect, have the greatest impact we can possibly have, at the same time as recognising there are a group of people that are hidden because they're not necessarily the ones on the ambulance, they're not necessarily the ones in care, and we do really need to focus on those.
Okay. And in policy terms, maybe Sam might want to answer this, or Nicola, or Jacqueline, there was this proposal by the previous Prime Minister, I think, to have a single person in charge in each place responsible for, particularly for delay. Is that something that's, is that melted away now, or is it still happening?
I think it was mooted in the white paper around integration, but that's certainly not come out in any guidance. I think what we do have in all of our places is a really strong local kind of focus, and we might not have a person who's responsible for health and social care services, discharge, admission issues, but we do in all of our places that I've certainly seen have got a really kind of close
Okay.
working.
Thank you. Dave, did you want to say anything about the areas that you have oversight for?
I think, Chair, it's a similar theme, really. I think the key issues, and it's Neil's point, actually, everybody's working really, really hard together to do the right thing for local people. And we talk about systems within systems, and obviously there's the urgent emergency care network as the big system, but a lot of the work actually happens very locally with colleagues in trusts, in general practice, in local authorities. There's an added bit that we sometimes forget about because we talk about North East North Cumbria, and that's the fact that in North Cumbria and also in the Tees patch, we do work with colleagues in neighbouring ICBs as well. So a lot of the pressure that we've seen in the south of the patch in my area isn't necessarily North East North Cumbria patients, but they're from North Yorkshire. But the key bit is, again, we work with colleagues in partnership to get it right, because people don't respect boundaries, they're just lines on a map, and we just need to make sure we do the best for them. But huge concerted effort. I think there's not one silver bullet for this, sadly. If there was, we'd have cracked it probably years ago, so we just need to keep chipping away and working on it. But the test is the test of the system, I think, which will actually be a good place for an ICB to get to support that.
Okay, thank you. Well, we focused on a few areas of Jacqueline's report in particular, but anybody else want to comment on those areas or any of the other points that she brought up in her report? I'll let you come in a second, Sam. Eileen.
I guess it's just while we're talking about the ambulance situation, and to just step back a bit. It's really hard when we're under such pressure to really step back and say how can we prevent some of this and some of the demands, particularly on our ambulance sector. A few years ago with NIAS, my team did a little bit of work trying to understand what proportion of ambulance rides and call-outs were linked to substance use and alcohol-related reasons. And around about kind of midnight to 3 a.m, 70% of the ambulance call-outs and rides were to do with people who were using substance or intoxicated. And actually we need to address some of that pressure on this bit of the system in order to free them to be able to be conveying people to hospital very poorly. So I think it's just a point at which, particularly as we're in the winter, we've heard everything today, we are under a lot of pressure and we're looking at what's happening, but at some stage in this sort of situation we need to step back and say, what are some of the things that we can look at to try to relieve some of the pressures on this system overall? And prevention is something there, and certainly for people who are having mental health and acute episode, when there is that sense that there isn't support around, again there is pressure on the ambulance system. So just a bit of a call really to step back and think about some of the things that we can do to take some of the pressure off.
Thank you. Sam.
Yeah, and thank you for that point, Eileen. I think that's absolutely been at the heart of the rapid improvement events, and we have got all of the data down to postcodes in terms of looking at ward level data as well. And I think there would certainly be no surprises when we look at areas of multiple deprivation in terms of higher numbers of conveyances to hospital. And of course, 33% of our population live in those areas. I just wanted to particularly pick up on North Cumbria. So North Cumbria is a part of our system, and as Dave and Nick have touched on, the differences, particularly around those parts of our system that border other areas. And of course, in North Cumbria, it's the North West ambulance service, not the North East ambulance service. So it's a different ambulance service. The other thing that's quite unique to North Cumbria is, whilst in the North East, when there are times of pressure at one of our hospital emergency departments, there's the opportunity for diverts. There is nowhere to divert to in North Cumbria. The two emergency departments there do take all of the ambulances, and they have actually established some really innovative ways of working, particularly around reducing ambulance handover delays. The reason why I'm mentioning this is it's the difference of place. And I think I just wanted to underline, I suppose, things most people have touched on, and Anne in particular, around actually, whilst there are a small number of things that we can tackle at the wider system level across the North East, North Cumbria, the vast majority of these solutions do lie at place, and therefore the relationships with all of the organisations. And I did want to specifically mention our hospices. We have 11 independent hospice providers across the system. They also play a part not here, and I met with them recently to talk about that, and also the work that we're doing around virtual wards. And I think she referred to, Jacqueline, the sort of the home first approach that we're taking. But most of these solutions do actually rely at place, and I think therefore it's really important that we continue to challenge ourselves where we are taking our decisions, and ensure that we get the resources out to place to enable their solutions to be put in place.
Thank you. Raj.
Thanks, Chair. Just when you asked about any other issues which we might want the board to be aware of, I mean, I've raised this with Jacqueline, but with regards to the mental health aspects within the report, there are significant pressures with people. At the moment, most of the providers are running at more than 100% occupancy rates, huge delayed discharges in that sector too. People with, sadly, who need detention under the Mental Health Act, not having to wait a long time to get a bed. And we've referred to this before, children waiting for weeks to get assessments for neurodevelopmental issues and so on. So I think there is work going on, but the report needs to reflect on some of these big issues, along with the mandated national ones, which is about dementia and IAP services and so on, for us to be really cognizant of what's going on.
Thank you. Jacqueline.
Thank you. Just to respond a little bit to a couple of those things. Firstly, in terms of
the microphone seems not. Yeah.
It takes a minute or two to kick in, doesn't it? Firstly, in relation to Eileen's point around really understanding what's in the ambulance queues, and even before they hit the ambulance queue, I suppose, what people have urgent need of on the day. That's something that we're getting more and more into, and as exactly as you described, we're trying to balance urgent actions to address this winter with an eye to what the longer term fixes may be. And you'll see when we get to the winter report that we've started to segment the information we've got around people who call ambulances, around the main reason for their call, and already developing plans around increasing the mental health and also the end of life care input into the ambulance services clinical triage arrangements, so that we can get more of those people to more appropriate community responses rather than them being brought in ambulances to the emergency department. I'll say a bit more about some of the measures that we've started to implement when we get to the report. And then just in relation to Rajan's comments, just to say that absolutely we've got a commitment to move beyond the metrics that are mandated nationally in relation to, if you like, our development, our delivery report, and identify the measures that are important to us. And just to give one example, we have developed a system control centre, which is going live this week. That's one of the asks in the winter letter. And unfortunately, no mental health measures have been defined nationally as being part of the things that we should be looking at. But we've made a commitment locally to have a dashboard around mental health emergency pressures in our system control centre, and be aware of what's going on, and use the resource we're putting into that centre to help implement mitigating actions when we get into situations of extreme surge. I don't want to suggest that this is a silver bullet. We know that there are some really deep-seated issues and that we've got real workforce challenges, but I think it's important that we, when we set up mechanisms such as the system control centre, that we're looking at the whole system and not just the acute system. So just wanted to provide that reassurance. Thanks.
Thank you. Mike.
3 points, if I may. The first two are very brief. The first is to thank Neil and for the work that he's led on with the ambulance handover delays and making a very decisive policy, really, with the 1 hour limit for handovers. I think that's a credit to how the ICB can function in making a difference really quickly across the region. The second is a point just to try and put some positive spin on the situation at the moment, really, and how things are going. Yesterday I had a patient who was unwell in my surgery, and I phoned for an ambulance for him. I was told that the wait would be around an hour for an urgent ambulance, which is about what the average is. And I called for one of our nurses to come and arrange a nebulizer for him. We'd been in there about 5 minutes waiting for the nurse to arrive. Someone knocked on my door, said, "Oh, that'll be the nurse for your nebulizer now." It was, in fact, the paramedics had turned up that quickly. So the average delay is there is still really good experiences going on as well. It's not as doom and gloom as it sometimes feels. The third, slightly longer point, really, is I tried to put some of these figures into context and visited one of our local foundation trust, and went from sort of start to finish across the trust to see the patient flow experience.
and it seemed to me that while the problems are multifactorial, the biggest problem seemed to stem from the back end of the hospital discharging patients, and that's why it's great to see the work that we've got coming up in the paper down the line. It would be really nice to have in the next report for this section to have perhaps a deep dive into the work that's being done under the discharge funding, just as maybe for the next meeting to see early signs of how things are going in that direction.
Okay, thank you. Neil.
Just a couple of points. Other ambulance services and their links in with our urgent emergency care network, Northwest Ambulance Service and Yorkshire Ambulance Service both have a seat on our network board. On the point about the prevention side of things, later on the agenda you'll see in the health inequalities, we are looking to invest in partnership with our local authorities into interventions to help people who have got issues with alcohol, substance misuse and more complex mental health problems. And on the North Cumbria issue, I spent an hour with Adrian Clements, the medical director over there. They are doing some fantastic work. You're right that they don't have the pressure valve of deflections, and I've made a commitment with Adrian to look at what could the system do to help North Cumbria if it did reach that point when it was full. Truly full. So we're going to do some quite rapid work just to look at what we can do to try and help that part of our system in the coming week.
Okay, thank you. Jacqueline, is there anything else to say on this report? No, thank you. Okay. Well, thank you very much for the report and the discussion. David.
Thank you. And thanks very much for a very comprehensive report, Jacqueline, which does include some information on general practice, although coming through to the Health Watch network, it's delayed access to timely appointments is still a concern. But there's still nothing on social care. This was mentioned during the last meeting, and I think the answer there was that discussions were ongoing with local authorities. So is the intention to bring information along the lines for the provider trusts for social care, difficult though that may be, or will this tend to be concentrated at place? But at the moment, there doesn't seem to be any reporting on social care issues, which is mentioned time and time again.
I think it's a really, really good point, David, and I think that we could look at that around workforce data. I think Mike's suggestion around a detailed look into delayed discharges. What we don't want to do is to get into lots of duplication, and I think we also need to be clear about our statutory responsibilities. It's not our job to regulate or oversee social care, but it's some of the key indicators that would support us taking that system-wide view. We do have a regular meeting with our directors of adult social care, and perhaps that's something we could take into the next meeting of that for a conversation, and we'll bring that back to this meeting.
Okay, thank you.
Okay then, thank you for a very helpful discussion on that paper. Can we move on now to item 7.4, and that's David Chandler, Interim Executive Director of Finance.
Okay, thank you, Chair. So I will take the paper as read, and what I'll remind members there is the Finance Performance and Investment Committee obviously review the finances every month, so I'll simply touch on the four main financial duties of the ICB and the wider ICS, and also a brief update on the financial outlook for next year following the most recent autumn statement. So the ICB has a duty to live within its resources that it's allocated. It's £6.5 billion. The ICB currently is forecasting a surplus against plan, against break-even of £5.6 million. That's an increase of £3 million since last time, and I'll touch on the reasons for that in a moment. The ICB itself, though, is reporting pressure on independent acute activity, also on packages of care. But on the offside of that, there are underspends on things like packages of care and slippage on reserves. And those things combined allow us to forecast an underspend of 5.6 million by year end. If we look at the wider ICS, and basically that incorporates all of our foundation trust providers, and when we add that to the ICB position, the plan was that the providers would have a deficit of £2.6 million at the end of the year, and when you combine that with the ICB position, you get to break even. At month 6, one of our foundation trusts signalled to their board and to NHS England and to the ICB they needed to reduce their forecast outturn from surplus to break even. The surplus that they had planned for was £5.6 million. So to offset that, the ICB was able to increase its surplus by £3 million, and one of our local foundation trusts, Southern South Tyneside Foundation Trust, were able to increase their forecast surplus by £2.6 million. And that combined kept the ICS in balance from a forecast outturn position point of view. Members will note in the report that I highlight that obviously there are risks in terms of achieving forecast outturn of break-even at year-end. Many of those lie in the provider sector, and you'll note I also include in the paper a bit more granular detail there. I talk about the risk on the NHS pay award. So additional funding was allocated to ourselves, £86 million for the pay award offer. That is approximately £20 million light based on our calculations. We've been working with NHS England and Foundation Trusts partners on that. To give credit to NHS England, they've been working very closely and very collaboratively with us in terms of understanding that and issues on that issue, and discussions do continue with NHS England on that, as well as with ICS Director of Finance in terms of mitigating that risk. The next two duties I'll just touch on. The first one is capital. So there is an expectation that we don't overspend our capital resource limit, commonly called the CDEL, but I won't use any acronyms, Chair. But just to say that there was a planned overspend on that at the start of the year. The latest indications, the latest forecast will be much closer to break even by end of year, and I'm relatively confident that's where we'll end at year end. We work very closely with our provider collaborative colleagues in terms of managing the capital budget of the year, which is £187 million. The last duty is running costs. We forecast running costs will be around £1 million under at this year end. Our more concerns are around next year and the year after, because the NHS pay award is very rarely funded in terms of an uplift on the NHS ICB running cost type budgets. So that's always a pressure every single year for us to manage. I'll just touch on, Chair, that's okay, some financial high-level pointers around next year following the autumn statement. So we're expecting an extra £3.3 billion as announced in the autumn statement, on top of what was already included in forecasts for the NHS, and also additional funding for social care, £2.8 billion next year and £4.7 the year after. Although my understanding, some of that from the King's Fund analysis includes charging reform delays and council tax increases. So sometimes the devil is in the detail in that regard. The NHS England had actually asked for £7 billion. £7 billion is a widely reported number. That number was based on indications around inflation at a point in time. And NHS England and the government have announced that actually the expectation is that inflation next year will be lower than at that point in time. But of course, what we will find out approximately around Christmas Eve, we normally get a Christmas Eve present, which is the financial settlement in more granular detail for NHS England and for ICBs, as well as the financial planning documentations and expectations. Around Christmas Eve, we'll get that granular detail, what that actually means at an ICB and an ICS level. We do expect, though, that will include an expectation of around a 3% cost reduction target for the NHS England. And that will be on top of any unachieved cost reduction plans from this financial year. So we expect it to be a very challenging year in 23-24 on NHS budgets. The last thing I'll just touch on very briefly, that's okay, Chair, is overspend protocol. There is a new NHS England overspend protocol, which we will review in much more detail at the Finance, Performance and Investment Committee. But in a nutshell, there are now more hurdles to jump over and more implications if a provider or an ICS indicates a deviation from financial plan. And part of our task in the Finance Performance and Investment Committee that John chairs will just be to understand the intricacies of that and what that actually means for us as a system. But also there's an opportunity for us to provide feedback to NHS England on how we think that should operate in reality to make sure there's no unintended consequences of that protocol, which I fear there may be some for financial planning purposes for next year. I'll leave it there, Chair, that's okay.
Thank you. Very clear, very comprehensive. Thank you very much, David. Any points anyone wants to raise on this? No, that's always a good sign if there's no questions about the money. So if we could now please take our break. We've only scheduled 10 minutes, which I think is a little unreasonable. Let's say 15, and ask you to be back in your seats at 11:15.
Inflation between
Okay, thank you very much. Welcome back. I have been notified that we have to leave the room at 1, so we can't run the meeting late. Turning then to item 7.5, and that's your item again, Jacqueline.
Thank you, Liam. So this is to present the Integrated Care Board approved oversight framework to the board for information assurance. So I'll just say a few words about it. It's really quite a significant piece of work that we undertook over the summer and into the early autumn, responding to NHS England's publication of its own oversight framework for 22-23, which set out some quite significant oversight responsibilities for ICBs. So we took that opportunity to develop a comprehensive oversight framework addressing the asks within the national framework, but also our own needs in terms of all of the business of the Integrated Care Board. And as it says in the covering paper, we decided to co-produce the oversight framework with those who would be participating in the oversight activities it covers, really to make sure that from the get-go the way that we were operating as an ICB was in line with our values and our ways of working, being a learning system and being very inclusive in the way that we develop our ways of working. So the oversight framework was presented to October's executive committee for consideration. We were pretty much where we wanted to be, but we decided to do some further socialisation with the system, which we did. So Ken may want to comment, but we took it to the chief execs meeting, having already had some significant involvement from the providers. Our executive directors of place, but represented by David and his colleagues, have been involved. And then we formally approved it in November. So we're going live with it as we speak. As the paper also references, there's some quite extensive work to do to ensure that we can operate this effectively, particularly around the business intelligence that needs to support the framework. I hope you'll see, if you've had a chance to revise the paper, that we've really embedded our values and sort of articulated how they would act in practice in terms of how the framework would operate. And also that you'll appreciate the degree to which we've ensured it covers all aspects of our business. So we've set out oversight frameworks not just for the provider trusts, but also for our programmes and also for our places. And indeed, we've set it in the context of our overall business planning round. So really trying to have a clear sort of cycle of business from how we set our strategy and then our annual plan, and how the deliverables in the annual plan are then pulled through to the oversight meetings, so that we're really looking at using the oversight framework not just for assurance purposes, but as a really powerful tool to see whether we're delivering our objectives. And then the last thing I wanted to mention was that link to support offer and to our learning framework. So a real focus within our oversight meetings will be, I think, to live the phrase that we've called being the best at getting better, and ensuring that we're taking every opportunity to draw learning from other parts of the system or more widely, nationally and internationally, and that we're deploying resource to the parts of our system that need the most help to achieve their objectives. So, as I say, it's not here for approval, but really for information and assurance that we've got effective arrangements in place. We do expect the NHS's arrangements to continue to evolve. It may be that further responsibilities are devolved to the ICB in 23-24, but I think we've set ourselves up well to be able to receive that. And as it says in the paper, we will review this at the end of the year, and then again on regular intervals to make sure that it's fit for purpose. Thanks very much.
Yeah. Are there any points anyone would like to raise on this? Go ahead, Eileen.
I'm probably going to make myself look extremely thick now. But when I was reading this last night and I finally got my highlights, obviously the chair of the Quality and Safety Committee, I saw there was mention of a system quality group, and I'm not familiar with that. And I would welcome just understanding what the system quality group is, as you know, separate from the Quality and Safety Committee. Yeah.
I'm going to defer to David for that, if I may.
So the ICB has a system quality group which looks at the quality in all our places. So it's an oversight, but it's a different meeting. So it's co-chaired by me and Jane Robinson from the DAS perspective, and it looks at the wider aspects of quality, and then that feeds up into the regional quality group. So it's what we used to have previously. It's a change of title and a change of focus to a wider system.
I think that's very helpful, and it emerged in our first Quality and Safety Committee, which I'll talk to later. And it's just for those of us as non-exec directors, just having visibility of all the sort of regional structures and groups. It's quite hard to see that and just see how everything relates. So the diagrams in this were really helpful, but there is a layer that isn't fully seen even in this helpful document, and we're catching up and we'll get there, but it just sometimes we need a little bit of help trying to understand what these groups are called and where they sit and how it works.
If I could just raise one point, Jacqueline, it's a reflection really as much as a question. When I came back into the shadow version of this role in February, appointed in February 2021, I hadn't been in the NHS really much for 10 years. I'd mainly been doing WHO and academic work. So it was interesting, having been heavily involved in all the previous versions of the NHS at regional and national level, and then even before that clinically. And there were a few things that struck me about it, but one of them that struck me very powerfully is that I felt there was a much less openness than there had been when I'd been in the NHS before. Some of it a consequence of the devolution of much more accountability and responsibility to trusts, and I'm not criticising that at all. But also, I think because the architecture of the clinical commissioning groups was quite elaborate and in parts fragmented. And so I had great trouble in taking an overview of a number of things, and in particular one of my interests in safety. I was a bit alarmed that there wasn't a proper flow of incidents coming in anywhere. Now, maybe that's a bit unfair, but I think of all of the things that need to be a strong feature of this. If we're going to be an ICS working as one team, is that everything needs to come into the open that should be in the open. And that's not just a benefit for being able to do the coordination and the planning and the oversight properly, but it's also from point of view of the public interest. So I like that transparency coming as the first bullet point on that list.
Yeah, thank you, Salim. I think there is a huge opportunity for us to sort of simplify the system. And as it says further on in the report, we are mapping all of the interactions in our system that currently go on and connecting them together. So we'll have if you like, a single source of information around issues and incidents that are occurring in any part of our system, the plans that have been developed to address them, and the progress on those plans, because I feel that some of the difficulties around transparency around the complexity of information flows and the different parts of the system. Just to briefly address Eileen's point, we're aiming for an integrated approach to governance, as we all recognise that has benefits. It's difficult to address safety issues without understanding the financial context and the workforce context. However, there are, if you like, issue-specific flows of assurance going on in the NHS from, if you like, ward or practice right up to the National Quality Board or the National Finance Infrastructure, so we'll have to also support those, and that's why I guess sometimes the diagrams get quite complex. But from an ICB point of view, we've had a discussion about how we address that, and our focus is very much on the integrated conversation with all of the data being together, so we can triangulate the causes of issues and possible solutions.
Thank you. Sam.
Thank you, Chairman. Just a couple of things, really. I just wanted to thank our Provider Collaborative for engaging in this. I think we are entering a sort of a new era of oversight, and the Collaborative have engaged incredibly well with us on this. And as Jacqueline said, we really do want to be a learning and improvement system. And I think, to your point, Liam, transparency and openness absolutely being at the heart of that, because if we are really going to be a learning and improvement system, we need to be sharing openly, not just our successes, but actually where perhaps things haven't gone as well as we would have liked, and what we've learned, and where we can take the lessons from that. I do think this issue of transparency and openness, just picking up on the previous conversation with Dr. Kirkup joining us in January, I think us thinking about that culturally in terms of we can put new structures in place for oversight, but it's how we shift and adapt our behaviours to be comfortable, essentially, with being uncomfortable around some of these discussions, because being transparent and open means that we do have to talk about some of the challenging aspects of what we do, and we need to do that in a transparent and open way. And I think we are a National Health Service. I think the public have very high expectations of us, and that includes being open and transparent about not just what's working well, but areas we're working to improve and how we're sharing that learning across our whole system. So I think the values and behaviours piece will be something we have to pay ongoing attention to, alongside looking at the intelligence, the indicators, the data, and how essentially we triangulate not just performance data, but people's feedback, views, external views, and most importantly, people's lived experience.
And I think I've said this many times before, that things that are difficult to do nationally, quickly anyway, we ought to be able to do with a population of nearly 3 million. But to think that in the 21st century, and this applies not just the UK but other than that, no board can sit and ask itself the question, are our service, how safe are our services? That question cannot be answered. There's no summary measure of it. Reporting, we know there's so much under-reporting, so any comparisons, you don't know whether it's a genuine difference in risk or whether it's just that some people are better at reporting than others. And we've got to be able to do something about that. It hasn't been possible nationally, but I think with our population and the expertise that's in here and the goodwill towards working together, we should be able to crack some of these problems and have a really good understanding of our services. Okay, any other points? I don't see any others. So we'll move on. David? No. Yeah, okay. So that's the oversight framework, thank you. And now the winter plan delivery. And that's item 7.6, and that's, again, your item, Jacqueline.
Chair, so I'm just logging on. Okay, thanks very much. So the board will recall that we've had iterations of our winter planning and enhanced operational resilience, as we call it. How are we organised to best respond to the additional pressures on our clinical services that we experienced during winter? We've had a couple of reports on this in prior meetings. So the report before you today, which we've touched on a number of times already this morning, is a kind of roundup of progress in all of the areas that we're working on in relation to winter. So my intention is just to, again, draw out a couple of highlights and give the opportunity for the board to discuss any of the matters raised in the report. So forgive me, I'm just... Okay. My apologies. So the report covers a couple of key developments since we last met. We've had further winter guidance published since the last public board meeting. And so one of the things that we've included in the report is a roundup of our progress against all of the, and there are many, asks in relation to the winter guidance. And so you have a table there in the report that goes through where we are in terms of progress. So I won't go through all of that in detail, but suffice to say we've done a very comprehensive review of all of the guidance that's been delivered to us in both August and October, and we're in a reasonably good position to meet all of that. I think some of the areas where there's further progress to make around are where we're expected to really look at changing pathways for patients in the way that we refer to her in the meeting. So if I take the first amber in the table around increasing increased provision to high-intensity users. So these are people who frequently call upon our urgent emergency services. There are opportunities to reshape services to better meet these people's needs, but it's not a short-term, if you like, intervention that we can put in Ready for Winter, but rather detailed work that we need to do in all of our places. And further on in the report, it refers to the establishment of what we've called community of practice. And so we are putting together a mechanism for our places to come together and learn from each other in terms of the pilots and new ways of working that many of them are currently implementing to try and enhance the offer to people who have an intense need for support in their communities. The second amber relates to maximising recruitment for new staff in primary care across winter. And you'll be aware that increasing primary care access is our second high priority. And I'll come to a bit of the work that we're doing there, but that's rated amber because, as we know, there are significant workforce challenges, and the opportunity to really substantially recruit additional primary care staff is somewhat limited in terms of the availability of the workforce, but we have therefore prioritised how we're deploying primary care staff in order to best use their capacity to meet urgent care needs, and that's through our ambulance service, triage service, and also in terms of trying to increase the primary care staff who are available in our urgent treatment centres. I'm going to move down the report now and just pull out some key highlights. For the first time in the report, we've started to provide some data against the 6 national metrics and the 3 local metrics that we identified. And they're on page 138 of the board pack. So just to remind you, that the national metrics, the first 3 relate to our ambulance service, the number of calls that are abandoned, answering call response times, and those category 2 ambulance response times that we looked at in the integrated delivery report. And then average hours lost to ambulance handovers delays, and we heard earlier the work that we're doing to try and optimise our ambulance handover arrangements and the, if you like, backstop target 59 minutes that we're going to implement across the system. And then a metric around the percentage of beds occupied by patients who no longer meet the criteria to reside. This is a term that refers to patients who could be discharged from hospital because they no longer have an acute medical need, but can't be discharged unless some support arrangements are put in place for them, either at home or via a care home bed. And then you'll recall from previous reports, we set 3 local metrics, and these relate to some of our priorities in our own local winter plan. The first is around increasing the number of people who dial 111 or 999, or indeed contact the 111 service online, who have their need what we call clinically triage, which means they get to speak to a clinician to help them direct to the most suitable care. And then a second metric, which is going to look at whether, as a result of that and the other interventions we're making in terms of community services, we can change where patients who contact 111 and 999 eventually go to receive their on-the-day care. And the objective is to see fewer patients being transferred to the emergency department and more patients appropriately dealt with in the community services. There's just a couple of other points, Chair, that I'd like to pull up in the report, and then I'm happy to take any questions. You've got an update in terms of vaccination, and Neil, the Chief Medical Officer, referred to that earlier. There is a couple of innovations that have started to take effect. So on page 142 of the report, you'll see that we're starting to gather detailed data on the impact of one of the interventions that's gone live since we last met. So if you recall, at the last board meeting, we talked about how we might meet that goal of providing more clinical triage. And one of the first interventions we identified was that we could potentially place a contract for additional clinical capacity for those patients who contact 111 online. And I'm pleased to report that that service actually went live on the 1st of November, and you can begin to see there that significant volumes of patients are now being clinically triaged by this alternative provider. And the idea there is that the core clinical triage service within the ambulance service is reserved for the more complex cases that come through the 999 route. So we're watching that carefully, but the early indications is that that's working effectively, and we should start to see some impact in terms of our metric of getting people to the right place at the right time. Further down the report, there's a table I'd like to draw your attention to relating to the 2-hour urgent community response standard. And again, some quite interesting data here, which suggests that we are seeing a steady increase in the number of patients who are getting access to an urgent community response. And this is really hopeful. Because there is real variance across the country at the degree to which these services, which are relatively recently implemented, are actually being taken up. And as we work through that community of practice across our 13, soon to be 14 places, we'll be providing these data at place level and really looking at how we can ensure that these services are made best use of. Elsewhere in the report, we talk about the opportunity to connect with some of the services that our local authorities provide. So we know that all 13 of our local authorities provide a 24-hour urgent response for falls to parts of their community. So through our community of practice, we're bringing our local authority and our health service providers of urgent community services together to look at how they can best meet needs. And that'd be really helpful to try and do better in terms of the patients who suffer falls. So we know that falls is a very high it's one of the most common reasons that people dial 999, and yet there's a high percentage of those individuals who don't need to go for a clinical assessment to an acute hospital, and there's an opportunity for us in our region to meet their needs better through these community services, so that's an area of focus for us. The paper also touches on 2 other pilots that we're doing through our rapid improvement work. One is with the Northumberland Specialist Emergency Care Hospital, who are working with the North East Ambulance Service to see whether some of the patients who are already in the what we call the stack, so the queue to have an ambulance collect them at home, can be clinically reviewed by a specialist in the hospital and directed into an alternative pathway. And we look forward to seeing the output of that work and whether there's learning we can apply more widely in the system. And then the final piece of innovation that I'd like to draw your attention to is that in the Tees Valley area, we're doing some work with the community matrons to look at whether they can look at the patients who are waiting for ambulances in the Tees Valley area and again identify individuals who can be better served by a community service. And again, these are pieces of work that we'll be reporting into our communities of practice and looking at the opportunity, if we do see a success, to spread those ways of working more broadly across our region. The last item that I wanted to refer to is the System Command Centre that we touched on very briefly earlier in the meeting. So this was an ask in the Going Further on Winter guidance that came out on the 18th of October, that Integrated Care Boards set up a 7-day-a-week System Command Centre to help support the system to respond to surges in demand and challenges in parts of the system. And this takes the form of both a virtual and a physical centre that's staffed between 8 a.m. and 8 p.m. 7 days a week, and is able to survey a wide range of metrics that gives an indication of what's going on in terms of waits for ambulances, waits in terms of ambulance handover, when our emergency departments are under extreme pressure, when we've got peaks in delayed discharges that could be causing flow problems, and start to work with the system to respond to that. Alongside the work to set up the system, we're doing some really detailed work with our providers on their own surge and response plans in order that we are able to see the system react responsively, and we're able to get a read across and where necessary get the system to support each other through mutual aid. So that would be one part of the system, temporarily taking additional patients from another part of the system in order to relieve pressure. So I think from the North East and North Cumbria point of view, we've done very well in terms of setting this up, very fortunate in terms of the quality of data we've got. So we've got much more live data than other parts of the country available to us through the work that we've done. And also we already had a surge team in place that we've been able to build on. So we are able to go live with that development this week, and I'll look forward to reporting its impact at future board meetings. So it's a very complicated paper, Chair, and I've tried to draw out some points of interest there. There's an awful lot going on. Happy to take any questions.
Yeah, thank you. There are some points of interest. On a historical note, I think probably only Ken might remember this, but on the coordination centre, the old regional health authority set one of these up for emergencies, and one we were awaiting to receive casualties from the Falklands War. It wasn't called an emergency assistant coordination centre. It was called a bunker. So we were in the bunker waiting for, and we were meant to liaise with a military facility called the Airhead Medical Services. And I was looking, at the time, I was the only one that was quite clued into modern culture, and the term airhead had a totally different meaning. But I couldn't seem to get that through to the military people. It wasn't a good. And then we evacuated some people from Montserrat who were being overwhelmed by the volcano. So we've an honourable tradition in setting up bunkers, and this is the latest one. Thank you. Any other comments or questions? Mike?
Thanks, Jacqueline, for another excellent report. There was some really exciting, innovative stuff in here, which is really great to see. I guess my question is, obviously this is non-recurrent funding that the region's getting for this, and it would be good to know which of these items are going to be the ones that have the biggest impact and the ones that we should therefore fund recurrently, and which ones at the end of winter we step down and decide maybe not to do again. Thinking about Celine's reflection that this has been done before, albeit in a slightly different way, so just to try and make sure that we learn from the experience. What's the plan in place for that?
You want to take that now?
Yeah,
We've got some
happy
other
to.
points as well.
That's a really good point. Thanks for raising that, Mike. And we are aware that's an issue. Although some of the funding is non-recurrent, there is often, every year in recent history there has been some non-recurrent funding for winter, so I think we can rely on elements of the funding being recurrent. That being said, I think there's 2 points to make in terms of your question. The one is that we're trying, as you can see from the paper, from the very get-go, measure the impact of these interventions so that we can make a considered judgment about whether they're worth rolling out more widely, continuing with, or stopping. The second point is that there's at least one example where we're making an intervention at cost, but at the same time doing some redesign work with the view that we might not need to maintain that short-term intervention. And the example I would give is in relation to the clinical triage. We're looking to move another large tranche of work to a third-party provider for a non-recurrent period over the winter in relation to a group of patients who are spoken to by a clinician within the ambulance service and then end up having a GP appointment booked for them. And what we're going to do is do some redesign work to see whether actually we can go straight to the booking for those patients and negate the need for that clinical intervention altogether. And therefore that would be a non-recurrent investment to get us through winter while we do that detailed design work alongside.
Thank you. Hannah?
Yeah, thank you. Thank you very much for that report. My question is about the role of pharmacies in some of these sort of initiatives, and also the extent to which data that might be held by pharmacies will feed into some of this sort of observation data that you're developing. Just as a bit of an anecdote, I know when I was chair of Age UK Teesside, we found that with a lot of our older, obviously it's all primarily older client group, pharmacies had a really important role to play in preventing some older people from having a sort of acute crisis that required an immediate emergency response. And just the other day I was speaking to an older woman who'd not been able to get hold, she was having some anxiety problems, so she hadn't been leaving the house. Therefore she hadn't gone to the pharmacy to collect medication for an ongoing chronic problem which she needed it for. Ultimately, because she hadn't taken that medication for several days, she then ended up in hospital quite seriously unwell. The pharmacy knows her and knows that she would normally come in regularly, and she hadn't. So they sort of had that intelligence, but nothing was acted on, and that data didn't seem to be captured anywhere. So I know it's just one example, but I just wondered what the role of pharmacies might be in some of this.
You want to take that one?
I can do. Thank you, Hannah. I think, again, another great question. We know that the pharmacies are a real trusted part of our health service, and I'm not sure if it's in this paper, but I think we previously reported that we've done some work in our region to put some pathways in place. So it's for urinary tract infection now. We have an innovative pathway where patients can go to their pharmacy, be tested, and have antibiotics dispensed without recourse to their GP. And we've got some good evidence that that's been taken up. And so we're looking at, we're both publicising that pathway, but also whether there are other examples of pathways that we can put in place with the pharmacy. In terms of your point about data, we've got another paper later on around the delegation of the Commission decommissioning of pharmacy, and that's something that's coming down to the Integrated Care Board in a few months' time. And I think that will give us an opportunity to work more closely with our pharmacy sector and leverage those data. And in terms of your specific point around that intelligence, I think that's probably more in the realms of a sort of quality improvement project we could do with colleagues in the pharmacy sector to think about how, as sort of anchors in the community who know their population, they might be empowered to act on that. I think we've previously heard examples of where people absolutely have, and it's that soft intelligence that sometimes is difficult to capture, but once we're able to do so, it can make a real difference for people.
Thank you, Ken.
Thanks. Liam, the title of this paper is Operational Resilience in its wider sense, and one of the things that I don't think maybe has had sufficient play in here is the operational resilience of our people. All of us, all FTs, all organisations will have some form of well-being programme, if I can call it that, looking at resilience and our people to undermine this. And it maybe doesn't get sufficient play in the paper itself, and I understand why. But it's just to reassure people, every organisation will be looking at this winter. We've already seen sickness levels starting to drift upwards across most of our organisations. We know it's going to be a challenging time. So we'll be putting in place as much of that as we possibly can on the ground. But our operational resilience, in many ways, is a bigger issue than a lot of the individual plans and processes we've got in this particular paper. So that's the first comment. The second comment is I'm going to be really interested to see the outcome of the Northumbria and NIAS example and looking at the stack. Because one of the things we do know is when you get experienced ED professionals, not just doctors, professionals, looking at patients on a stack, they will take a different view on the risk associated with those papers compared to others. And I think if we can tease some of that out as part of their experience and use that elsewhere, that will be very valuable in how we approach that across the whole of the North East and North Cumbria.
Ken, for those not familiar with the term, can you define a stack?
It's basically, as it is, it's a stack of patients who are on NIAS systems awaiting either access to NIAS or transport to hospital.
Right. Okay. And
horrible description, but it kind of gives you the...
Yes. Okay, thank you. John.
Just a quick one from me. I think we discussed already in relation to the South Tees area and also to North Cumbria, in terms of that control centre, as it were. That's going to cover everything in terms of our whole geographical area, and also as well link into the other, presumably, command centres that they're operating in maybe other areas as well. Is that the plan?
It is.
Right.
So if, for example, you're asking about Cumbria and the link
Yes.
into North West Ambulance Service, we'll have those data available to us in the command centre, and also for the sort of south of our patch, the Yorkshire Ambulance Service. We have developed a sort of 4+1 model in the region, so there is a close link with the other three command centres in the region, and indeed through to a regional hub. And so I'd say we had a good kind of head start here, and so our plans are slightly more developed. In fact, much of what we've developed has been shared with other parts of the region, and in Yorkshire they've chosen actually to have a single side-by-side hub for the three integrated care boards together. So I'm confident that we'll have a clear connection. And in fact, we've had something that's described as a call cadence issued this week. So there will be a daily conversation between the ICSs and the region, and indeed between the region and the national team. So I think we'll have really high visibility of the activity of these command centres. But those kind of horizontal and vertical connections are baked in.
Thank you.
Yeah.
Okay, thank you, Dave Gallagher. Thank you. Okay. And David Thompson.
Thank you. Just three very, very quick points in terms of vaccines. In the early days, there was significant confusion, misinformation, particularly for homeless people, but they have been largely revolved, and we're very grateful for that, as everyone is. But still issues perhaps with rurality for vaccinations, and also children with health issues not always being directed to the most appropriate place for discharging, and a huge amount of work is taking place there. And the issue of pharmacies has already been mentioned. And in terms of cost of living, a plea from the Health Watch organisations, if there's information from any organisation about fuel poverty, cost of living, would you please try to send it to the Health Watch representatives in your local area, because they'd be very, very keen to promote that information to the widest possible community. So if there is any information on that, as there is, please send it to the Health Watch, the local Health Watch, and we'll do our utmost to make sure it is widely circulated.
Thank you very much,
Yeah, thank
David.
you.
Sam.
Thank you, Chair. Two points. I wanted to pick up the point Ken raised around workforce. Absolutely right. The resilience of our workforce is really critical, and we know that our workforce is continuing to recover from the last 2 years. And we also have a vacancy rate across the whole of the health service. So they're working incredibly hard. And I think we're really fortunate here in the North East, North Cumbria, with our people, incredibly committed to their communities. I just wanted to share that the workforce resilience hubs that had been put in during COVID to particularly support health and social care staff, and this is a service that's provided by one of our mental health trusts. Nationally, they are withdrawing the funding for these from the 1st of April. We have discussed that as a system. We think it's incredibly important that we continue to support our workforce over what we do predict will be a challenging period, and we'll be working up a business case in terms of what have we learned, what do we need, and maintaining some of that support. And then secondly, I just wanted to just make sure that we've drawn the distinction between an emergency control room, which we have and we can stand up at any time to respond to any type of emergency incident across the system, and the strategic coordination centre, as we're calling it. These have been mandated nationally by NHS England specifically to help manage risk over what is going to be a challenging period operationally. So it's the management of risk, but the oversight of the whole system. Where we'd want to get to is, and I think, Eileen, this picks up a point you made earlier around actually prevention and early intervention, is if we can draw on our data and utilise it to start to forecast and predict surges so that we can take mitigating actions ahead of that, as opposed to responding to the situation where there may be slightly more ambulances queuing wherever they are, and increased patient need. And this will be mobilised at our offices in Sunderland, and just encourage members of the board over the next couple of months, if you'd like to come through and see this in action, you'd be very welcome to come and visit and see it. And again, just to thank our partners across the system who've helped us mobilise this. I think it's really important, alongside having that the physical space, we also have all of the data available virtually, particularly given the size of our system, and we have enabled that. And Graham, thank you for leading that, working with our partners.
Just picking up, maybe this is one for Neil, or maybe you, Jacqueline, Hannah's comment about a vulnerable patient. Given all the work that went on early on in COVID to classify people's level of vulnerability and working with supermarkets and banks and everything, what's happened to all of that data?
So we're just looking at all the different vulnerable groups, because that was people who were clinically vulnerable to COVID. This is a wider thing, working with kind of our ADAS colleagues in terms of vulnerability, in terms of deprivation. So some of the stories that we're hearing is really tragic, that people who have on home ventilation overnight are not switching it on because of the cost of it. So they're the groups of people. So we're looking at all of those different vulnerable groups, and we'll send that to
the data's been adapted
to and added to.
Okay.
And we'll send that to them.
Okay, thank you. Right. Yes, Mike, go ahead.
Just going back to the strategic centres, Sam, you mentioned that the data will be available virtually as well as obviously for the centres. It would be nice as an aspiration to look to try and make whatever data that is publicly accessible. So I appreciate some of it will be sensitive and personal information which can't be shared. But I think, as was demonstrated in the pandemic with the COVID dashboards nationally, that transparency and public scrutiny can be really valuable at providing extra insights that we may not spot internally.
Yes.
If if I may just respond, I absolutely agree with you, and certainly even could envisage a point in the future where the public can see what the current waiting time is in certain parts of the system. We have that data. We should be looking to support our population, people in our community, to self-manage and to be able to take decisions based on access to that data.
Okay, thank you. If we could move on then, thank you very much, Jacqueline. This one's yours, shared with David.
Thank you, Chair. So this is a combined paper that David and I and our teams have pulled together just to give the board an overview of where we are in relation to the delegation of some of the services that are currently commissioned by NHS England. So it felt right to put the two things together, but they are on slightly different tracks. So I guess we'll start with the primary care and the pharmacy, optometry and dental services, and I'll defer to David for that.
Thanks, Jacqueline. So the two different timescales you suggested there, and actually the primary care side of things, while ICBs already have delegated responsibility for general practice, the other three professions, pharmacy, optometry and dental, are heading our way for next financial year. We've already touched on some of the opportunities there in terms of some of the linkage of the pharmacies. There's a real big opportunity here for some progress in terms of integrating services much better at a local level. However, there's some challenges and risks which the paper outlines, some particular challenges in terms of, at the moment, this is managed by NHS England colleagues. There's an infrastructure around NHS England at a regional level, and we're just trying to do some work to understand how we'd get access to that, whether staff would move across, whether it'd be embedded or how things would work. So the paper includes two particular parts. There's a pre-delegation assessment framework that's been completed, which has highlighted some risks. We're now through a group that we've got overseeing the governance and the transfer of the pod functions, working on something, looking at the safe delegation checklist, which in essence is something between ourselves and NHS England that will look at the due diligence, if you like, of transferring across. It'll highlight the risks and how we manage and mitigate them. So we've got a system in progress, more work to be done on this, and we'll bring a report back to the board closer to the time of proposed delegation, which is 1st of April next year.
Bits, if that's
well, just if there's any, I remember again during the shadow period of the ICB, this was said to be a complex piece of work to receive, and is it still seen in that way?
It's certainly got its complexities, and as I said, there's some challenges there. But I think the delegation checklist that I talked about will help us work our way through that. And I think, as with everything, it's about everybody going at this with eyes wide open. So we understand what the risks are, how we mitigate them, and how we move forward.
Okay, thank you. Neil?
Just one point. A lot of the delegated functions are administration of nationally agreed contracts.
Yeah.
Where I think the real opportunity is getting into the transformation space. So that we do have staff who've got expertise, well, they're currently sat in NHS England at administering these national contracts. As long as we get some of that down, then we can start to see how we can transform and join some of these essential community services together.
Okay, thank you. Move on to the next slide.
Yeah, so very briefly, because you have the paper before you, similar process, slightly different timeline. So we have agreed with NHS England that formal delegation of those specialist services that are deemed suitable for delegation to ICBs, and the suitability is really around the population they serve and whether we're able to deliver a kind of independent service for our population. There are some services that will remain nationally commissioned because they're for such rare or complex conditions that they cover bigger populations than our footprint. So just a couple of things to draw out, if I may, Chair. There's a proposition from NHS England that we establish what they are calling a joint committee in order to have ICB involvement in key decisions in the shadow period, which is 23-24. Now, we've had a number of conversations about what this means, and as far as we can discern, although they're using the term joint committee, they don't actually mean to establish a committee where there is joint accountability for either the spend or the service decisions which will have implications for patients. Rather, we'll have ICB members of an NHS England committee, but all of the accountability will remain with NHS England until the delegation occurs on the 1st of April 2024. We are hearing informally that potentially they may want to do that on a larger footprint than North East and North Cumbria, but they haven't let us know that formally. So at the moment, the proposition is there'd be one committee for the North East, North Cumbria footprint and one for the Yorkshire and Humber footprint. Similarly to the pod delegation, we've done I've got it written down here, Pre-Delegation Assurance Framework, or PDAF. So in common with the way that commissioning has been prosecuted by NHS England for the last number of years, it's an extremely detailed assurance framework. And although delegation's not happening for specialist commissioning for another 18 months, we have nonetheless completed that framework and started to work through all the complexities. Just to give a sense of scale, there's a plan to delegate, I think, 67 of the 154 service lines, but it's the majority of the spend. It's £501 million worth of specialist commissioning spend against an overall spend for our population of 711. So just a couple of issues I'd like to raise. One is around the financial risk, because we know that along the same timeline as delegation, there is an intention to change the allocation approach from one that is historically based to one that is needs-based, and we don't understand the detail of that, so clearly that carries some risk for us, and we need to understand that in more detail, and we'll obviously aim to do that through the transitional period as part of our due diligence. The second issue is one around how we maintain momentum to sort out some of the issues we've got in terms of service sustainability or delivery of new ways of working during the transition. So we're keen to ensure that there isn't a sort of interregnum of progress. And also that we're really clear what the areas of highest concern and risk are in relation to improvements needed to our specialist services. So we'll be working closely with NHS England during the transition period to make sure that we maintain focus and progress on all of those issues. The last thing I would say is that, building on what Neil had to say, there is an opportunity here, because we do know that across our services there are examples of specialties that are part specialist commissioned, part was CCG, now ICB commissioned, and that can lead to fragmentation and difficulty in service planning. So there's an opportunity for us to take a holistic review of those services once we have total responsibility for commissioning for the whole pathway, and so we'll be taking the opportunity to look at our own internal arrangements. So rather than just lifting and shifting, if you like, the specialist commissioning team from NHS England into the ICB, we're doing a detailed piece of work on how we commission and contract per se in the ICB, so that we've got the best arrangement for our population. That's all I wanted to say. Thank you.
Thank you. It's a long time since I've looked at a list of specialist services. I mean, if you look at Annex 1, it's a long list, and it would just be interesting to see the extent to which any of these have limited capacity or workforce shortages. I would guess quite a lot of them do. And so there's obviously there's a planning element to this as well. It's not just commissioning year by year. It's looking forward a bit. If you take something, for example, like specialist paediatric urology services, obviously if you haven't got, there's a very delicate surgery. If you haven't got trained surgeons in the pipeline, you'd be running into difficulty with that. And then I guess just looking at some of the titles without knowing too much about the detail, one or two of these seem to me have been mainstreamed now, and whether you would want to keep them classified in that way as they're obviously specialist services, but not necessarily so specialised that you would want to treat them any differently. So I think there's probably some revisiting of the concept, if possible, unless we're constrained by national rules from doing that.
So I think, as we sort of intimated, that's a real opportunity for us. As Neil mentioned, though, although we'll get delegated commissioning responsibility, we won't have delegated authority to deviate from the national service specifications. And I think that is sometimes problematic because they vary in approach and quality, and some of them are very input focused. So that's something that I think we'll continue to have a dialogue about nationally for some of those services. But I suppose the upside of those very detailed service specs is we have a lot of knowledge about the sorts of service issues that you're referring to there, Chair, because there are lots of service standards that are required to be met through the SpecCom system, and a formal sort of derogation process where there are any issues. So we've got a good visibility of where we've got service issues in those services that are being delegated to us.
I suppose it's just an inherent worry I've got that that maybe a Royal College or a specialist body reviews these things every 4 or 5 years, and in the meantime things are happening that you'd want to try and take the benefit. I mean, for example, visiting South Tees last week and talking to the cardiology team and hearing them talking about their ability now to treat some forms of heart failure with high-tech interventions. Now, I would bet that hasn't made its way yet onto the
No, it's still,
no, I mean,
still
maybe it
specialist
has,
mission.
maybe it
Yeah,
hasn't,
yeah.
but it seemed to me,
Yeah.
for a very large life and death area of care, a great opportunity that we could jump on. So, I think we probably can do a lot more with this than first met the eye whenever the idea was talked about of delegating it.
Chair, if I may, I completely agree with you. This isn't without risk, but I think one of the aspects that's almost unique to us as an integrated care system is the vast majority, almost 100% of these specialist services are delivered within our system. Now, most other integrated care boards and systems would be, their patients will be having to travel to specialist centres outside of their system. So I think if we grasp this, it has to come, Ken, with the support of the provider collaborative too, in terms of the transformation around the pathways and the clinical services, and particularly thinking about sustainability for the reasons that you outlined, Chair.
Anything you want to add, Ken?
No, I would agree with that. I think many of the providers, particularly the more complex specialist providers, particularly Newcastle, are getting quite frustrated, I think, with some aspects of the way SpecCom works nationally. So I think getting a little more of that, with the risks clearly identified, into our ICS ICB is a good thing. But you're right, most of this is delivered by us in one shape or another. Very few of our patients are going to the true national stuff. But there will be some issues about sustainability on numbers for us to look at. So it does come with some, not just financial risks, some other risks we just got to go, somebody said it already, into this with their eyes open. But providers will be engaged in this agenda, absolutely.
Yeah, thank you. David?
Very, very quick. If I just go back to dentistry, it would be very, very remiss of me not to mention that of all the issues raised within the Health Watchers, dentistry is by far the most significant, which, bearing in mind ambulance response times and so on, that's quite significant. And there are now in the northeast North Cumbria areas which are effectively dental deserts, and this is in those areas having very serious effects on the population at large, and particularly with those people who are already disadvantaged. I have never seen information coming through from the wider public as much as this one, solely on dentistry.
Okay, thank you very much, David. Well, just with an eye on time. Yes, David, go ahead.
Sorry, with time I'll be really brief, David, but it's a really good point that David makes about the dental deserts. And we need to be really reassured that the finances we receive cover need and don't take account of the fact that maybe we're not spending a lot of money in certain areas, so we don't need as much. So we've definitely got an eye on that to make sure we've got the resources to try and sort that out. Okay.
Thank you. Well, thank you very much. You've had a good run of papers, and so I'm very grateful. Right, so we're now on to a number of items which shouldn't take too long, but they're important. So first of all, Sam, on the establishing the Integrated Care Partnership, which, as you know, is the other board structure which is running alongside the ICB.
Thank you, Chair. So we've got quite a comprehensive paper, which I won't cover because I'm sure you've gone through this. But the purpose of bringing this today is to seek your views. So hopefully there will be views. You will have views to share on this. So just briefly, the Integrated Care Partnership, the Strategic Integrated Care Partnership for the North East and North Cumbria. We've had one meeting. We have our next meeting in December, where we will be receiving the terms of reference, and you'll see we've updated the membership slightly in the terms of reference. This is a joint committee between the ICB, the Integrated Care Board, and our 13, soon to be in April 14, local authorities. And the core membership consists of our Health and Wellbeing Board chairs and lead officers from the local authorities. We've also extended that to include universities, hospices, police, fire and rescue, for example. The board real focus is developing our integrated care strategy, which is out in draft format for feedback at the moment, and they'll be receiving that for discussion and digesting some more in December. But it is to improve the health outcomes of the people of North East North Cumbria. The Joint Management Executive Group that Sir Liam chairs has been really instrumental in shaping our strategic partnership, and alongside and supporting the strategic partnership across the North East North Cumbria, we have 4 area integrated care partnerships, and they're in the process of getting up and running a meeting for the first time this month. And they have a really important role because whilst I think one of the reflections I certainly had from the first integrated care partnership, there's a lot more that unites us across the North East and North Cumbria than divides us. Actually taking that local, more place-based focus to build the strategy for the system is incredibly important. And I know those area integrated care partnerships will also be reviewing the draft strategy and making sure that it does reflect all aspects of the needs of their local places, and enabling the strategic integrated care partnership to prioritise those areas of greater focus across the North East and North Cumbria. So it's here today for your comments, and I'll leave it there, Chair.
Okay, thank you very much. Well, you'll be hearing more about this, but for now, are there any points anyone wants to raise? No. Okay, thank you very much. Some technical amendments to our constitution, Claire Riley.
Yeah, I think the paper is self-explanatory, Chair. I'm happy to answer any questions. There is a summary of the technical changes in the summary front sheet, but I'll leave it at that, Chair.
Okay. Any points anyone wants to raise there? Thank you. Right, so we're now on to the important business of getting a report back from each of our committee chairs on their first or second meeting, early on anyway in the process. And I think to make a general point before calling on each of the chairs, that we do have a lot of business coming our way from, as I've said at the beginning, from taking over the role of the clinical commissioning groups, and also a very active period of central guidance, whether it's on current priorities, winter planning, and so on. Hence, we have a heavy agenda each month, every 2 months, but also the committees have a heavy agenda. But it's important that you are cited on them. You get a copy of the minutes. You get a summary of the key elements of each meeting, but also either during this discussion today or subsequently when you've had the chance to read the minutes, if you want to request anything should come to the main board meeting rather than be received through a committee report, you must let us know. Because obviously there's some important things there, and we may not have taken decisions to include them where you think we should include them. So let's move through. And the first is the executive committee, and Sam's going to. And this is chaired by Sam and involves the all of the executive directors as well as the secretariat.
Thank you, Chair. So we've got the highlight report and the minutes and the papers. Just in terms of drawing out some key issues, we did an after-action review following the National Cyber event that impacted particularly some of our urgent and emergency care, out-of-hours services, and also some of the financial systems. This was a national issue. Now, cyber does feature on our risk register and will continue to do so. We certainly believe that we've got the risks mitigated at the moment, but this is an issue, a risk that we will face, and I know certainly Graham and the team have been making sure that we're mitigating that insofar as possible, but we did draw out the learning from that national event. In terms of urgent emergency care, it's featured quite strongly, quite rightly on our agenda today. We have done a whole overview of the governance approach to this, and we have that in place, and that is jointly chaired, as we know, by our Medical Director Neil and one of the Chief Operating Officers from the Foundation Trust. And we've also, working very closely with our Director of Public Health, overhauled our health inequalities arrangements. So we're now really in the process of starting to implement that. I think that will go through a period of bedding down. I'm pretty sure in terms of the audit committee, perhaps in the first quarter of next year we would probably want to get that on our internal audit plan to have a look at that in terms of the effectiveness of it, but also the funding and the outcomes linked to the schemes that we've supported through health inequalities.
Thanks, Sam. You've got a slide up there. Is that covers what you've said?
Well, we've covered the oversight arrangement. The only other area just to pull out is we have invested in the establishment of a primary care collaborative for the system. So you'll find that deeply buried in the minutes, but we're certainly working with our primary care colleagues around the development of that, and just wanted to highlight that.
Okay. And the summary of the key points, if you want to look at it, as I say, and decide whether you need to know more about it, either offline or through a proper board discussion, then please let us know. But are there any points for now? No? Okay, then we have the Quality and Safety Committee, and Eileen Kaner is the chair of that.
Yes, thank you, Liam. Happy to report back on our first inaugural meeting of the Quality and Safety Committee in October. We began by really trying to think about what we were there for and what the vision really of this group is about. And we were really delighted that Liam rang in from Australia to give us the benefit of his experience working in particularly quality and safety over many, many years. Liam's a welcome observer to the meeting, although not a voting member. But we really wanted to make sure that we first do no harm. Safety is absolutely crucial to us, but we also then want to think about clinical effectiveness and care effectiveness and efficiency, and then also patient experience. So it is really hard, I think, to mend your roof on a rainy day. But if you don't do that, things are going to get worse. And we know that we're under a lot of pressures. But we have to think about quality and what we can do better rather than just looking at what we do, etc. So there are some, matters of business. We looked at our terms of reference and the cycles of business and the reports that we get. And I've put in the bullet points there, the reports that we will regularly get. But some issues are rising. We felt really strongly that we wanted to have more public voice in this meeting. And there is certainly a request to think about lay representation. And I believe Claire is going to bring a paper with recommendations about how we might best do that. We want to ground this work in the experience of people and patients and their family members, etc. We also looked at our membership and we wondered really, given that many of the risks that we will think about and the actions we need to think about to take to mitigate those risks, that we didn't see social care representation in our membership. We had public health representation through Tom Hall, but not social care there. And if we think about some of the issues we've discussed today, around the ambulance services and ambulance discharge, these matters are deeply interconnected with our partners in the social care sector. So we really wanted to reflect upon that in our terms of reference and then the membership of this committee. There were some comments about where things are done and that we don't really want to duplicate. We do need that transparency we mentioned earlier to understand what might be structures and groups that exist in the region, so we know what's done where and then what needs to be done at this group. But I think I'll finish before I hand to Hannah to see if there's anything Hannah wants to add. I think as a group we felt that We wanted to make sure that we could balance what is urgent, what comes flying at us in the system, with also what is important. How can we think about a prevention agenda, as well as actually just thinking about the pressures that our system is under. We have a lot of data in these meetings, and I think we as a group want to think about data that gives us insight, as well as allowing us to have oversight of what's going on in the system. And I'll finish by saying that John Rush and I have had many conversations. I am vice to John's group on finance performance and investment, and we were trying to discuss what's performance and what's quality. And I think we are in a situation where we will have one unified report that will come to the two groups, but we will pull out for our own specific focus, and here it will be about some of the kind of quality issues that we want to address and help be the best at getting better. Hannah, is there anything you'd like to add?
Thank you very much. I guess, just to emphasise the point around wanting to move towards that prevention and not having a group that simply looks retrospectively at problems that have already occurred and then getting stuck in that kind of operational management of crisis all the time and not being able to actually forecast or observe or predict or indeed think about some of those broader initiatives that align with the core objectives of the ICB in tackling these kind of big problems like health inequalities, which we'll never do if we're only ever hearing we have health inequalities. We already know that. It's how do we use the data and the evidence in this group to try and push towards something that matches those strategic aims and objectives.
Okay, thank you. Any points? Anyone wants to questions they want to ask? Yes, Eileen.
I should have said.
Ask yourself a question. You're quite free to do that.
Racing for time. We have this integrated report, and we just need to make sure that the overall summative number of risks and the risks that come to each committee are absolutely accurate, but we wanted some consideration of additional risks that we didn't see. One was around workforce that we've talked a lot about today. The other one was about children's mental health, as well as adult mental health services, and the third one was around prescribing, and I think pharmacy has been mentioned a few times today.
Okay, thank you. Right, and then the final report, John, is from you, from your...
And just in terms of, I'm not going to go through those two key points around financial position and performance, because I think we've covered them quite well today, but I just wanted to pick up on a few things that are on there. Firstly, I wanted to say a big thank you to David and to Jacqueline for the information that we get and how we get it. And I think we've come a long way in a relatively short space of time, particularly in relation to the integrated report, and particularly in the way that David's just trying to link in as well, not just obviously with us as a committee, but also the wider partnership and the financial directors as well in the provider trust and across the ICB framework as well. But just a couple of things on there. One is that we've got a meeting on Thursday, and we're going to have a first paper there about historical CCG surpluses, and I think it will be quite contentious in terms of what that actually means. These are areas of our geography which, when there were CCGs, are given additional surpluses to account for, and we have to work out what we're going to do with those as an ICB. So there's an initial paper there that we're going to have a discussion about. And then the other bit, in terms of number 4 there, there's from the papers and the information that David has presented to us, we know that in terms of funding for us as an ICB, based on the NHS allocations, we could be struggling a little bit, and I think you did touch on that next year. So there's a group being set up, which David is going to oversee, just in relation to trying to work out, are we doing everything that we need to do in terms of how we code things correctly to make sure that actually are we being done out of something that we should be having in terms of some funding, so we can respond back to NHS England and say we think this. So there's some work being done on that. And again, the revision of terms of reference, I had hoped that today we'd be able to bring the sort of formal paper just to get those things finally sorted out. But we've got a little bit of work to do, which we'll pick up again on Thursday, just to finalise. It's just the timings of the meetings didn't help us, to be perfectly honest with you. But we'll hopefully, by the time it comes to the next board meeting, we'll have something there about the terms of reference, and we can get those signed off as well. So that was probably all I wanted to say on those things, really.
Anything anybody wants to ask John at this point? No? Okay, well, thank you, and thank you to all the committee chairs, because you've summarised very well what I know were a range of very complex discussions, and still early days for working out how you're going to handle all of this. So thank you. Right, we have a few items to finish. The 9.6, the scheme of reservation and delegation. Neil, that's curiously yours. It doesn't look like it would be yours, but
it is. Yes, I know. I mean, it's very brief. I assume you've read the paper, but it's under me because it relates to the individual funding request process which I oversee. We agreed our scheme of reservation delegation when we established our board, but we weren't specific within that about the delegation on the individual funding requests that come through. So there's a new entry into the scheme of reservation delegation which delegates to the IFR panels to allow them to make decisions on individual funding requests, and also down to individual members that are appointed as decision makers. Just to give the board some reassurance, the decision makers administer the individual funding requests as per our agreed value-based commissioning policies, which are reviewed regularly. From the 1st of July up until now, I have been agreeing all of them, so I'm really quite keen for this to be agreed, because there's about 20 a week. So yes, it's just really to sharpen up that scheme of reservation.
Okay. Yeah, there seems to be agreement. Having said that, I think we probably, all of us that are not involved, find it quite daunting to note the volume of stuff that you're having to. Do you feel properly supported, and do you feel there's a assurance mechanism around you?
Yes, yeah. Absolutely. We've got well agreed policies which we're here. Our decision makers are there. They're well trained. The IFR panels are set up. John's involved in them as well, and we're looking to see how we can streamline our decision-making panels as well to move towards 2 of them across the ICS rather than currently 3. So yes, there's a good process in place.
Okay, thank you. Well, moving on then, Neil. This one is also yours. Item 9.7.
Thank you. So again, this is just an update for board really about how we are progressing our work on streamlining the governance and our approach towards managing health inequalities. I gave a brief update at last board. We have progressed, and there's more updates since the time this paper was written. We've decided to, and we've taken it to Management Executive, to establish a healthier and fairer committee across a healthier and fairer advisory group, across the ICS, which will be the overarching strategic group that will provide direct assurance to our management executive and therefore the board on how we are doing as a system in progressing the health inequalities prevention and population health management improvements. I've done a lot of work with the directors of public health and working with voluntary sector and other partners in the formation of this group and the terms of reference, because this agenda, quite rightly, crosses a lot of organisations, and we need a system approach to that. We've agreed, as I say, some broad membership of the Healthier and Fairer advisory group. However, the initial meeting will be very much about, have we got the right people here? What do we think about our governance, so that we can use that initial group to further tweak and develop, and we'll bring further updates back. The approach that we're taking is that the Healthier and Fairer advisory group will have a co-chairing arrangement with myself and a director of public health, and we've specified that that's currently the chair of the DPH network, which is Amanda Healy. Underneath the Healthier and Fairer subcommittee, we've got 3 broad headings, which will be prevention, Core 20+5, which will include children's Core 20+5, and the NHS support to broader social and economic disparities. There are a number of other work streams. When I bring further updates, we're just tidying up the terms of reference and work plans for all them. I'll be able to bring a more comprehensive update of exactly what work streams are underneath them, so the board's well sighted on where all this kind of joins together. There are 3 enabling work programmes to our Healthier and Fairer subcommittee, which is population health management, which is an enabler, our community asset-based approach, which is going to be chaired by Von, and workforce development as well. Also within the paper, the NHS has an allocated budget for improving health inequalities, particularly around general health inequalities and health care access inequalities as well. There's a recurrent fund of nearly 13 million, which is across which is this year and across the following 2 years. We've agreed some broad headings which have been agreed by management executive about where we will be looking to focus that funding over the coming 2 years. Hopefully you can see there's quite a broad range of initiatives that we are suggesting that funding is targeted towards. Using we're complementing place-based approaches with funding that's been allocated to local authorities. There's a lot of detail to work up behind some of these programmes. Some of them are ready to go. So, for instance, one of the big areas of funding is our Waiting Well approach, which is under the heading of inclusively restoring NHS services. But we've tried to look at areas where we think will have the greatest impact, and as I say, they are detailed within there, and we'll be able to report on the progress and some of the outcomes we're getting in future board meetings. So I'm happy to take any questions on that, but yeah, they're the main points.
Okay. Questions, comments? I think just before you come in, Sam, only thing I'd want to flag up, I think, is that we don't often get special allocations for health inequalities, and I think we should take every opportunity to evaluate the impact of it, because there's been so little evaluation in times gone by, and it looks, I mean, you've obviously got a group of experts who've advised on how the budget should be spent, and I'm sure the board wouldn't want to second guess that, but certainly to know what's worked and what hasn't worked would be very, very important.
So built into the funding there is a section for evaluation of these initiatives, so we'll be able to report back on that.
We turn to one of our experts first, Eileen.
First to say, I really welcome this paper. Thank you, Neil. We've had a little exchange offline here. I was really happy to see, Liam, you've picked this up really. You know, the intention to have best evidence drive what we do. So we need to move, in terms of health inequalities, to stop just describing the problem and re-describing the problem and move to action. But we have to base our action on as much evidence as we have, and where we don't have evidence, we need to evaluate so we can generate an evidence base. I would come in here because I direct our applied research collaboration, and we are mentioned. That includes all 6 universities in the North East and North Cumbria and 60 health and care organisations working together to try to generate evidence around what we do in the health and care system. We have national leadership in prevention and inequalities, and we run 2 national priority area consortia, one on health and care inequalities and the other one on prevention, early intervention, you know, looking at risk factors. I've mentioned that it would be enormously helpful to have input from our ARC lead on prevention, early intervention and behaviour change, which is Professor Ashley Adamson. She also directs the National School of Public Health Research and sits in our region, as well as membership from our lead on inequalities, and our inequalities theme is inequalities and marginalised communities. So we do need to understand wider determinants and upstream drivers of inequality, but we also need to know how do we support the most vulnerable and most marginalised individuals in our communities. And we are enormously fortunate to have Professor Claire Bamborough lead that theme for us in the ARC, and she's also a well-established national leader. So I'm keen to make sure that we, through those 2 individuals, can bring the collective experience that we hold in our region and also some of the activity we've got underway. So prior to the ICB being in place, we did come to the previous structure, the Prevention Board, and say to the Prevention Board, what's the one thing that you would want us to try to take forward with the ARC nationally? What came back was the long-term planned rollout of hospital-initiated smoking cessation support. We secured about £400,000. We are leading in 8 regions an evaluation of the rollout of the long-term plan of that initiative, and there are many others that we can mention. So one thing I would say just as a final point is where there are evaluations going on, and I am part of a national evaluation of alcohol care teams, we need to make sure we leave that for what's already funded so we can use what you hold for evaluation to provide evaluative input around what is not currently being taken forward in that way.
Okay, thank you. Hannah.
Yes, thank you. A lot of the points I was going to raise, Eileen's already said them far more articulately than I would. But the main thing I was just wondering, and thank you very much for this work, I think it's really important and would be keen to support it in any way that would be helpful. But whilst we have, and Eileen's already said we have lots of kind of important data that we can draw on and studies that are ongoing where actually that work's already been done and so we don't need to repeat it. But also some of the challenges that we face in the North East, we might face them more so than other places, but they're often not unique to us. And so I'm wondering what the intention is or what the scope might be to work with other ICBs and ICPs and ICSs in order to kind of look at what they've done in relation to some of these things so that we can actually learn more widely than just locally, which obviously the local context is important, but it's not the only important context.
Neil, we'll just gather all the comments and then you can respond. So you've had Eileen, Hannah, Nicola.
Yeah, mine's kind of almost stating the obvious, but I would take us back to the very first presentation we had today about 24 years. And whilst people with learning disability and autistic people are mentioned through here, I think it's important that it's more than mentioned and that we're really clear that we work with those communities, those groups who've got all of that expertise and experience about what would work for them, so we don't lose sight of that within here.
Thank you. David.
Thank you very much for the report, which is very, very well thought out. And pleased that there's a commitment to engage with the wider community and particularly with the seldom heard groups, because such qualitative information can really add value to the work which you were doing. So look forward to it. There are many more issues, but raise them at the first meeting. Thank you.
Thank you. Neil.
Just to pick up on some of those points, on Eileen's points, I absolutely agree. We just need to use all of the best expertise that we have in our region to get the evaluation right so we can build that evidence base. On learning from others, there, as you can imagine, as ICSs are starting to really focus in on this work, there is the start of a national network, which I've plugged a couple of my medical directors in to attend and bring back any learning and share anything that we have. And obviously on the learning disabilities, they are a group that are included in the Core 20+5, which there will be specific reporting back on those groups through our management exec and through the board on how we're progressing and reducing those health inequalities.
Yeah. I'm going to have to ask you to explain that. Not everybody will know the Core 20+5.
So Core 20+5 is a national initiative which, again, going back to the evidence, it looks at the Core 20, which are the individuals who live in the kind of 20% least, most deprived areas of our population. And then it looks at 5 health indicators, or 5 groups and then health indicators under that, where if we make improvements, then there is evidence behind that will reduce health inequalities. The plus is some flexibility for local populations to identify specific areas of population that may not have been picked up by that national approach, so we can do some focused work towards that.
Okay, thank you. Any other comments on this? Yes, Sam.
Just wanted to pick up the point around sharing and the opportunities to work with other integrated care systems. We've got lots of opportunities through whether it's the NHS Confederation, ICS network, our incoming Director of Population Health, Dr. Edward Kanunga, and I presented at the King's Fund conference yesterday, separate presentations on this. So there's a lot of good work underway nationally. There's a lot of excellent work here in the North East, North Cumbria, and I think we've got many different networks in which we can share that, Hannah.
Yes, AJ's.
To Sam's point, Edward and myself sit on a regional population health management roundtable where we share amongst the 4 northeastern Yorkshire ICS's case studies on good practice around the region, so we can keep feeding that back up to this.
Eileen.
Just a further word on the applied research collaborations. There's 15 in England, so it's not just a local sort of enterprise. They're a bit interesting because they actually have to work in deep partnership with colleagues, partners in the system, and also public members. Certainly, there are 7 national priority area consortia where all 15 ARCs are working together around mental health, working at multimorbidity, looking at maternity and child health, as well as prevention inequalities. And there's one more I've probably forgotten. They are evaluating the rollout of lots of national and regional innovations and trying to kind of bring very practical evidence together. So there is quite a lot of learning that can be done through these national priority area consortia. And again, happy to sort of feed in as they do their work. They are quite coming through at different levels of maturity, but they're on a 2-year cycle to try to drive toward impact. And we're moving toward the point where they should now starting to be understanding certainly some of the lived experience and then some of the impact of some of the initiatives that are out there that are being evaluated.
Okay, thank you very much indeed. Actually, we have, before we do the board assurance framework, it might be convenient, Claire, we have a question submitted from a member of the public about this, suggesting that there should be a role for a patient representative. I don't know whether you can respond to that.
Yeah, no problem. And really good question. And we are working with Healthwatch as detailed in this strategy that came to our July, our first board meeting in this room, looking at the implementation of that strategy, which includes representation across a wide range of groups, including the Healthier and Fairer advisory group. We are also looking at the model for involvement and engagement, and in particular lived experience across our work streams, our networks, and we've already discussed it on a number of papers today around involvement in our committee work too. So next year will be our year of transformation with regards to involvement and lived experience, and we are working really hard to just lock down on that implementation plan, and we'll be able to update the board early in the new year.
Okay, thank you very much. We move on then to your item, Claire, item 9.8, the board assurance framework.
Thank you, Chair. This is the first board assurance framework that we've brought to board, and it will no doubt evolve over time. It is aimed at providing assurance on the management of our key risks. Hopefully we've been able to capture them for our integrated care board. There are 2 appendices attached to the document. First is the first draft of the BAF, but also our corporate risk register. I am happy to answer any questions. We are asking the board to review what is detailed within the BAF and also the corporate risk register, but also satisfy ourselves that it reflects both the objectives but also the risks that our board are dealing with. I'm happy to answer any questions.
Are there any points anyone wants to raise now? If you think of any, and get in touch with us, and you might want to have time to study this properly and get back to us. You're very, very much welcome that. Thank you. Item 10, we've responded to one question that was submitted in advance. Were there any others submitted?
No.
No. Could I ask if any of those attending under the category of public today have any points they want to raise or questions? No? We don't have any other business because we asked you at the beginning and you said no. So we are now closing in good time to avoid embarrassment with a group of the mayor's choosing coming into this room at 1 o'clock. So the lunch is next door. So thank you, everybody, and look forward to seeing you next time.